Yes, sir.
पधारो मारो देश मोनिका मैडम ने सांगा
सर बिल्कुल आइए सर, हम तो बुला रहे हैं, राजस्थान आओ पधारो। हम आपको
Sir,
टाइगर
नमस्कार।
दिखाएं, हम तो टाइगर्स वाली कंट्री उसमें हैं।
यस यस एमसी सर नमस्ते एमसी सर
नमस्ते 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 स्वागत है
हाँ केम छो साधो छे બધા સારો છે
हेलो
सर मला दोन्ही सांगायचं केम छो पण आणि
फुल
कसे
है फुल
आहेत.
है
अबे अबे अपन एमसी सर को भी सिखा देंगे ना
नहीं नहीं मैं काफी तो सीख गया हूँ क्योंकि प्रवास इतने रहे ना मैं महाराष्ट्र में
हाँ,
समझ तो पूरा लेता हूँ
हम्म,
बात करो मैं
भावना,
पूरी
वेटिंग
बता
फॉर
दूं
योर
कि क्या
काउंटडाउन
बात है।
प्लीज.
हम्म.
Yes, ma'am, we are live now.
Yeah.
I'll share the screen. A very good evening, all the respected dignitaries. Today, we are gathered here for the Happy Learning webinar series, master webinar series, in association with Aurangabad, Hingoli, Nanded, and Prabhani, which is upon Urogyne practice updates. So, moving ahead, I would like to invite our very beloved convener, Dr. Monica Umbadan, who is CP Elect Public Awareness Committee FOXY. Ma'am, I welcome you, please, to take the session.
Thank you, Bhavna, and thank you, Team Corona, for the technical help always. This is the 219th masterclass of the Happy Learning webinar series, and today we are hosting it in association with Aurangabad, Hingoli, Nanded, and Parbhani districts. And today's theme is the Urogyne practice updates. So, the program director of today's webinar is none other than Dr. MC Patel, sir, who has been the past vice president of WOXI. He is a well-known medical legal consultant throughout India. Sir is also an active Rotarian who operates free of cost since the last 43 years in the Northeast. And sir is the go-to person in case of any medical legal help that a FOXY member needs. His patience, perseverance, and passion for teaching right from COVID is we have seen as culminating into the 219th episode today. With the blessings of Lord Almighty, let's us begin the webinar today. Can we have the inauguration slide, please? Bhavna? The next slide and the inauguration prayer, please. Let us also thank our coordinators, Dr. Monica Gupta Madam, Dr. Deepika, Dr. Shatabdi De, Dr. Nivedita Datta, and Dr. Megha Kamlapurkar for being there with us throughout all the programs. Thank you, Bhavna. I welcome Dr. MC Patel, sir, on this platform to welcome our August gathering. Patel, sir. Savita ma'am, can you please mute yourself? Over to you, sir. Patel, sir.
Yes. Thank you, Dr. Monica, for kind words. It gives me immense pleasure to welcome you all on 219th episode of Happy Learning Masterclass web series. And just mention today with Aurangabad, Hingoli, Nanded, and Parabni. I welcome Dr. Kananbala Elikar Madam. She has kindly consented to be chief guest
Bhavana,
to
stop
bless the
sharing the
webinar.
slides, please.
And of course, she is always with us in any of our academic activity. Thank you, madam, for sparing time to bless us. Welcome, madam. I also
Thank you, sir.
welcome guest of honor, Dr. Rajendra Singh Pardesi, good old friend in Foxy since years together. So welcome, Dr. Pardesi, sir. And same Dr. Kishore Atnurkar from Nanded. Welcome. We both have kindly consented to be guest of honor, and you are going to bless this webinar. I also welcome one more guest of honor, Dr. Pandit Paluskar. He will join us soon, and we will have blessings from him also. I also welcome all the learned chairpersons who have kindly consented to chair respective session. Dr. Bhagyasri Ranjwan Madam from Aurangabad, Dr. Savita Wagmare Madam from Parabni, Dr. Meghasri from Nanded. They are going to chair a very important session of anatomy and physiology of SUI, and which is to be delivered by none other than Dr. Anil Sakre from Nanded. I also welcome one more set of chairperson, Dr. Krishna Pawar from Parabni, Dr. Vinayak Khedkar from Aurangabad, Dr. Ramesh Ahuja from Parabni, and they are going to chair a very interesting session, management of SUI revisited, and which is going to be delivered by Dr. Vinit Mishra. I also welcome one more set of chairperson, Dr. Ajay Mane from Aurangabad, Dr. Supriya Pandit from Nanded, and Dr. Archana Saraf Madam from Hingoli, and they are going to chair session about medico-legal issues in urogynec practice that I will cover. I also welcome two learned moderators who are going to moderate very interesting panel on complications of hysterectomy. Dr. Tasnim Fazia from Nanded, Dr. Dinesh Pratapar from Nanded, and two experts joining today, Dr. Srinivas Gadappa from Aurangabad and Dr. Lakshmi Rajkanna Madam from Aurangabad. I also welcome all the learned panelists who are going to put their inputs during panel discussion, making this panel very interesting. Dr. Dilip Nagargok from Gangakhed, Dr. Ananya Mahale from Nanded, Dr. Nagappa Niture from Nanded, Dr. Pranjali Khan Joshi from Nanded, Aparna Rahul from Aurangabad, Deepak Gatti from Parabni, Sipra Kate from Nanded, Narendra Verma from Parabni, and Dr. Sapna Partani from Parabni. I also welcome my team, Dr. Monica Ambardhan, she is convener for this series, and all the coordinator, Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Satabdi Day, Dr. Deepika Lugani, and Dr. Megha Kamlapurkar, and all the president and secretary of respective societies who have joined this webinar, and all the delegates. So today we are going to discuss urogynec related some issues. And when I started this series long back during era of COVID, my intention was just to say hello to our Foxian friend in that era of COVID when physical meeting was not possible, and to discuss very focused topic. And ultimate goal was to brush up our knowledge and to check maternal mortality, infant mortality, and medico-legal issues which we face nowadays in a big number. And as far as gynecologists are concerned, we are in a number one position. So we should be very careful for the same. And that is why we usually discuss one topic related to medical issues also. So with this little background, welcoming you all again. Thank you very much. Over to you, Monica.
Thank you so much, sir, for the coordinators and the convener for this program. I would now take the privilege to introduce our chief guest, Dr. Kananbala Elikar Madam today. Madam has been the teacher of teachers, yet the most approachable and the most humble person that I have met. Bhavna, can we have Madam CV slide, please? Madam slide, please. Yeah, thank you. Madam has been awarded the MCI Dr. B.C. Roy National Award among the category to recognize the merit of eminent medical teachers in 2009, which was conferred by the hands of Sri Pranab Mukherjee sir at Rashtrapati Bhavan, the President of India. She has set up the High Dependency Unit, the first of its kind in the state of Maharashtra, which was awarded the Safe Motherhood Award by the government of Maharashtra. She is the past dean of the Government Medical College and Hospital at Aurangabad since 2016. She has been nominated and shortlisted for the post of Vice Chancellor of MUHS Nashik, elected as the President of AMOX from 2016 to 2018. And she has been the past VP of FOXI the year of 2007. Madam has been the chairperson of the Clinical Research Committee of FOXI and the various other organizations. She holds the Limca Book of Record and the Guinness Book of World Record. She also has the Lord of Planet Award for the extraordinary services to human race and women's health conferred in the House of Lords at London. Madam also has received the V for Stree Award by the hands of Sri Bhagat Singh Koshyari sir, the Governor of Maharashtra. And Madam has been a part of the Government Medical College Nagpur with the Platinum Year in 2023. Madam, it is an honor to welcome you on this platform of the Happy Learning webinar series, and over to you for your blessings.
Thank you, Dr. Monica, first of all. And of course, our hero, Dr. MC Patel, sir, and who is still young at heart and so much of energetic and passionate about teaching. Sir, thank you for inviting me. And these webinars were really meaningful, especially during the time of COVID. And we had really enjoyed his seminar since 2020. And it's a great thing that he has kept his passion for the last 6 years. And sir, we wish you a very good luck for the post of President Foxy, and we would try to help you in whatever way you want us to work for you. Thank you,
Thank
sir.
you, madam. Thank you, madam. Obliged.
Oh, I would now request Dr. Monica Gupta, Madam, to please introduce our guest of honor for today.
Thank you, Monica, for giving me this opportunity, and thank you, MC Patel, sir, for making me a part of this prestigious webinar. Today, our guest of honor are Dr. Rajendra Singh Pardesi, sir. Please put the CV. Though sir doesn't require any introduction, everybody knows him very well. He was a past Vice President Foxy, President Amox, and
It's okay.
he was a
We can skip.
chairperson, sir. You were the chairperson of the Food and Drug Committee, and you got the Best Committee Award for that. And you are always working very hard in the national and international levels. We are really proud of you, sir. Over to
Thank
you,
you.
sir, for your blessings.
Thank you, Dr. Monica, for kind introduction. Good evening, everybody. Respected chief guest, Dr. Kanan Elikar ma'am. She is not only teacher, but she is our mother figure, not only in Marathwada and Vidarbha region, but for all Maharashtra. Guest of honors, Dr. Pandit Palaskar and Dr. Kishore Atnurkar sir. Dr. Pandit Palaskar, past president IIG. Dr. Kishore Atnurkar, a totally social minded of Gaini, a great writer and social worker also. And welcome Dr. MC Patel sir, Dr. Ajay Mane, Dr. Vinit Mishra sir, past vice presidents of Foxy. First, I wish to congratulate program director of this Happy Learning program, Dr. MC Patel sir, convener Dr. Monica Umbardhan, and coordinators Dr. Monica Gupta, Dr. Deepika Logani, Dr. Shatabdi De, Dr. Nivedita Datta, Dr. Megha Kamlapur, and also with all four societies, our societies. This is Aurangabad, Nanded, Parbhani, and Hingoli. It's our societies, and congratulations for these societies for taking actively participation in this program by Dr. MC Patel sir. with the galaxy of speakers, chairpersons, and experts, as Dr. M.C. Patel told. I think this is going to be a great event. I wish every success to Dr. Anil Sakre. You must not be knowing, but he is a hardcore vaginal surgeon from Nanded and our region. I wish every success to Dr. Anil for his future endeavor in forthcoming FOXI election as chairperson of Vaginal Surgery Committee FOXI. And at the same time, Dr. M.C. Patel. Dr. M.C. Patel is our friend since a long in FOXI, and he is a human. He is a good human. I wish every success to Dr. M.C. Patel, sir, for his presidential election in forthcoming elections of FOXI. I think he is the right person for the post of President FOXI. Sir, best wishes.
Thank you, sir.
Wishing every success to this webinar and this great event. Jai Sri Ram.
Yes, thank you, sir. Thank you. Thank you for sparing time and blessing us.
Thank you, sir, for your kind words. Please put the next CV. Dr. Kishore Atnukar, sir. He is a MD and MS in psychology, counseling and psychotherapy. And he's a consultant in private sector for 34 years. And he has done so many work in the field of gynae and obstetrics and performed more than 10,000 cesarean section. And he is very keen on the social work and he has written many books for the public awareness. Over to you, sir, for your kind words.
Okay, first of all, thank you very much. Good evening to all. Thank you very much, Patel sir, for inviting me as a guest of honor for this academic session. See, Patel sir, you are batting and you have scored double century. It is 219th edition of this happy learning. So you already scored a double century on this pitch, and it is not easy to maintain the consistency as far as these academic sessions are concerned. So first of all, congratulations for scoring double century. Secondly, you deserve, you have selected so many topics related to obstetric gynae, but I'm very happy to learn urogynec updates. Actually, the world related to obstetric gynec is moving through this technology related to infertility and sonography, fetal medicine and all. But urogynec appears to be little less concerned to many of the academicians, and so you selecting this topic for today's webinar or this academic activity is really great. It will be very useful for all those who are going to attend this academic activity or webinar. And I thank you very much for inviting me. It has given me an opportunity to listen to all those names from Aurangabad, Parbhani, Hingoli society. Just as Pardesi has mentioned, so many of my friends are here. And after all, Erikar madam, I have seen her after many days. Well, thank you very much for Patel sir for making me to meet all of them in one stroke. So, and I wish all very best for this academic activity. And as I told you, Patel sir, on our telephonic conversation, that we really want you to see in the seat of President FOXI. And this time we will जरा जोर लगा के हैया करेंगे, and
Thank you.
we really wish that you should be a FOXI president this year. Thank you again. Thank you very much.
Thank you, Kishore Bhau. You are always with me in any of my activity. So thank you for sparing time for this webinar also.
Thank you, sir.
Thank you, sir. Our next guest of honor is Dr. Pandit Palsarkar, sir. He is a endoscopist and a past president of IAGE. Please put his CV. And he is running many of the FOXY and IAGE approved training center for endoscopy, infertility, and ultrasound. And he is being invited as a faculty nationally and internationally and published many papers on it. Over to you, sir, for your kind word.
Hi, good evening, everybody. Thank you, Dr. MC Patel, sir, Dr. Anil Sakre, for inviting me on this August platform. I can see our seniors and our respected guest of honors, Dr. Kanan Elikar Madam, Dr. Rajendra Singh Pardesi, Dr. Atnurkar sir, and Dr. Ramesh Ahuja, and so many great friends from Marathwada region. So it's really a great CME. As Dr. Kishore Atnurkar has mentioned, we discuss very common topics, but I think this SUI is very rarely discussed. So I'm very happy that you have organized this CME on the management, the anatomy, physiology, management options, and the medical legal issues in the management of the stress urinary incontinence. We have various methods starting from medications. We have various slings, Birch-Calpo suspension, and I'm very sure you have chosen very best of the faculties in this field of the stress urinary incontinence, and delegates will be benefited which treatment modality to be chosen for which patient. And the other topic is complications of the hysterectomy. Hysterectomy, I think it is the most common surgery performed in gynec. So we should know what complications the hysterectomy can have, and we can take the preventive measures to prevent these complications. So I'm very happy to attend this webinar, and thank you so much for giving me this opportunity. I wish you all the best, MC Patel sir, for your presidential, FOXY presidential elections, and Dr. Anil Sakre, our great friend, for the chairperson of the Vaginal Surgeries Committee. So we are already started your campaigning. You don't worry. This time, we are sure you will win this election. So all the best for this your elections. We are all with you, sir. Thank you so much.
Thank you, Dr. Pandit, for sparing time. You are very busy laparoscopic surgeon, I know, but even then you have spare time for us. It shows your love and affection to us. So thank you.
We are always there for you, sir.
Oh, yes, always.
Thank you, sir. And over to Dr. Monica for further proceedings.
Thank you, Dr. Monica, ma'am. We now declare that the inauguration is over, and with an appeal that all of us will support the presidential candidature of Dr. MC Patel, sir, we move on to the academic session. And I would now invite Dr. Deepika Logane, madam, to conduct the first session, which will be taken by Dr. Anil Sakre, sir. And we will be concentrating on the anatomy and physiology of SUI.
So, thank you. Good evening, everyone. Thank you, Dr. MC Patel, sir, and Dr. Monica for giving me this opportunity. And we now begin with our scientific session, number 1, of this 219th edition of Happy Learning Masterclass web series. It is my pleasure to introduce our esteemed chairpersons for this session. We start with our first chairperson, Dr. Bhagyashree Sudhir Ranjwan, ma'am. Ma'am is the Secretary of Aurangabad Obs and Gynae Society. Ma'am has also previously served as the Honorary Treasurer of the Aurangabad Society and was also the Managing Committee member of the AOGS. Ma'am has contributed as an author to several book chapters and has presented papers at numerous conferences and is a regular faculty at state and national level academic programs. Welcome, ma'am. Can we have the next slide, please? Our next chairperson is Dr. Savita Wagmare, ma'am. Madam is the president of Parbhani Obs and Gynae Society. Ma'am is the director of Wagmare Hospital at Jintur and is actively involved in several social and community initiatives. Ma'am has received numerous awards for her contributions to social service and women's healthcare and is widely respected for her dedicated work in the region. Welcome, ma'am. Can we have the next slide, please? The next slide, yeah. Yes. So our third chairperson for the first session is Dr. Megashri Deshmukh Kaharkal, ma'am. Ma'am is the president of the Nanded Obs and Gynae Society. Ma'am is a senior consultant at the Sushruta Hospital and ICSI and Test Tube Baby Center at Nanded. Madam has received advanced training in infertility and advanced laparohysteroscopy and is credited with establishing a modular ICSI and IVF laboratory in Nanded. Welcome, ma'am, to our session and our webinar. Can I request our chairpersons to introduce our speaker, our first speaker for the session, who's none other than Dr. Anil Sakhare, sir, who will be speaking on anatomy and physiology of SUI. So can our chairpersons introduce the speaker, please? Dr. Savita, ma'am, are you there?
Yes, ma'am.
Yeah, ma'am, can you see the CV? Can you introduce, sir?
Yes, yes.
Hanji, ma'am.
Our today's first speaker is Dr. Anil Sakhare. He is a gynecologist, ex-associate professor, Department of OBGY, Government Medical College, Nanded. Work as assistant professor at GMC Nanded for 11 years, under and postgraduate teacher and examiner, operating faculty of live surgical workshop at various national conferences, 23 scientific publication in various national and international journals, amongst very few Indians who have contributed in Williams textbook of obstetrics. He is amongst one of them. Contributed in international reference book of operative obstetrics by Cunningham. Served to African countries and operated hundreds of cases there through Rotary Medical Health Camps. Experience of operating more than 7,000 NDH cases. He is now he is presently working as a chairperson, presented as a chairperson for Vaginal Surgery Committee for upcoming elections. He is a classmate of mine. I am happy to present his CV. So over to Madam.
Sir, welcome, sir. So
Thank you, ma'am. Thank you, Savita, ma'am, for the kind
Welcome,
introduction.
sir.
Thank you, ma'am. I must thank the organizers, especially Dr. MC Patel, sir, for inviting me on this big platform. I must thank his organizing team, especially Dr. Monica Gupta, ma'am, Dr. Monica Ubardhan, ma'am, Dr. Deepika, ma'am, and all his team for making this event possible today. And I was really surprised and very happy that it is more than 200 such webinars sir has been conducted. I must thank to my teacher, Dr. Erika ma'am, my mentor, Dr. Pardeshi sir, and all the today's guest of honor for being there and for making me a part of this event. Thank you very much. Can I share my screen?
Yes, sir.
So today I'm going to talk on anatomy and physiology of continence in females. Though it is a very complex topic regarding understanding the exact anatomy and physiology of continence, but I tried to make it more simpler for better understanding, and I have put some animated videos in my talk so that it can be easily understood. So urinary continence in female is the ability to store urine at low intravesical pressure and voluntarily prevent leakage until maturation is socially appropriate. Female continence depends on the interaction between the bladder urethra, pelvic floor muscles, connective tissue supports, and an intact neural control system. These five components are major components for female continence. The female lower urinary tract is uniquely vulnerable to dysfunction due to short urethral length, childbirth, and hormonal influences. So coming to the first main organ of this anatomy of the main organ of female continence system is the urinary bladder. All we know that it is a hollow muscular pelvic organ lies in the pelvis, and it is lined by the urothelium. And the detrusor muscle is the most major component of this female urinary bladder. And as we can say that this bladder lies anteriorly between the symphysis pubis and the transverse fascialis muscle, and posteriorly between the vagina, rectum, and laterally it is being attached to the endopelvic fascia. So these are the arbitrary boundaries of urinary bladder, and it is said that the maximum amount of urine that it can store is up to 2 liters of urine. It can hold, this urinary bladder bag can hold the maximum of 2 liters of urine at one time. So that is the stretchability of this urinary bladder. So coming to the histopath of this urinary bladder, though it is a triangular, at its base lies an internal urethral sphincter, which is an involuntary sphincter, and it has a trigone at its base, where at the ends of this the two openings of ureters and the internal urethral sphincter forms the trigone of the bladder. So this is the basic anatomy. And when we see the histopathology of this urinary bladder, it mostly composite of urothelium, that is transitional epithelium. The medial layer is lamina propria, which is very important. It contains the blood vessels, nerve endings, and the lymphatics, and it is maintains the compliance of the bladder. This lamina propria, because it acts as a center to send the signals to from the urinary bladder to the central nervous system. That's why the lamina propria layer is very important. The other layer is in submucosa, and after submucosa there lies a muscularis layer that we call it detrusor muscles. And these detrusor muscles is a smooth muscle, and it contains some receptors. The muscarinic receptors, that is M2 and M3 receptors, and the adrenergic, that is alpha and beta receptors. Beta receptors mainly present on the detrusor muscle, and alpha receptors they mainly present on the internal urethral sphincter. So coming to the second part of the female urinary system, the female urethra. It is almost 3 to 4 centimeter in length. It runs along the anterior vaginal wall, exits the urogenital diaphragm at the top of the introitus, and it extends from the bladder neck to the external urethral meatus, and it is mainly from the internal sphincter to the external, that is, it is 3 to 4 centimeter in length. So coming to the histopathology of this urethra, it also lies in a mucosal fold, which are mainly estrogen dependent. These folds, when they make a circular folds all along its length, that close the lumen of the urethra, and that these folds also help in maintaining the continence. The submucosal layers, the smooth muscle layer, longitudinal and longitudinal muscles and circular muscles. And the main component of this urethra is the external urethral meatus, which contains the skeletal muscles. But internal urethral meatus doesn't. It contains the smooth muscle layer, which continues with the detrusor muscle. That's why, as the external urethral sphincter is a voluntarily controlled, that's why it contains the skeletal muscles. Coming to the third component is pelvic floor muscles. It is very important component for the continence, female urinary continence. It contains the levator ana group, that means the puborectalis muscle, pubococcygeus muscles, and ilococcygeus muscle. These three groups forms the levator ana group of muscles, which supports the pelvis and gives a very strong support to the pelvic organs, also in abdominal organs also. And it gives the main support to the bladder and bladder neck and urethra. So this pelvic muscle floor maintains the closure pressure when we are in a not in a micturition phase. They maintain the closure pressure of the urethra, and it also they maintain the guarding reflex. What does it mean that guarding? When we cough, when we sneeze, so suddenly there is an increase in intra-abdominal pressure that may open the sphincters because of this sudden rise in intra-abdominal pressure. But these pelvic floor muscles guarding reflex contracts and they close the urethra strongly, so they maintain the continence. So this is the important function of these pelvic floor muscles. The other component, most important component, is fascial and ligamentous support, which keeps urethra and bladder attached to the lateral pelvic wall. The endopelvic fascia, which contains, this is a complex tissue, contains the connective tissue, smooth muscles, and lymphatics and blood vessels and nerves, all these things. The major component of this endopelvic fascia, pivourethral ligaments, which encircles the urethra. This ligament starts from the PVC, encircles the urethra and supports the urethra. And the other major component is arcus tendinis. That arcus tendinis fascia pelvis, which lies laterally, which anchors the bladder to the lateral pelvic wall. And the anterior vaginal wall also helps in gives some support to the urethra and bladder. So this is the animated video of we can all imagine that how the endopelvic fascia is there, how the this levator muscle, pelvic floor muscle supports the urethra and bladder. This is the beautiful animation which can really explain how the endopelvic fascia and pelvic floor muscle supports the bladder. The white structure which you are seeing is endopelvic fascia. These are the pelvic floor muscles. This is tuberectalis muscle. So you can imagine how the base of this bladder and the urethra is supported by these endopelvic fascia and pelvic floor muscles to maintain the continence. So regarding the pelvic floor muscles and guarding reflex, how? So these are the pelvic floor muscles. So when there is a sudden rise in intra-abdominal pressure, these pelvic floor muscles contracts voluntarily.
Lift them up inside. Muscles. You need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten.
So
Just switch on.
the last or important component is the neural control of continence. That is most important. All this physiology of urinary continence is controlled by the brain, and in the brain, in the hypothalamus, that is the frontal cortex, which controls the voluntary control of micturition, and the pontine continence center, which lies in the pontines, which coordinate the signals from the spinal cord to the hypothalamus. So these are the two main structures which controls the voluntary control of the urine. And only human beings are the only creatures on this earth that they have a neural control of continence which lies in their brain. All other animals, they don't have. So peripheral innervation is the second component of this neuronal system. That is the one hypogastric nerve starting from S1, L11, L12 to S1, S2, S3. The pelvic nerves, which starts from the bladder wall, that enters into the spinal cord and which sends signals to the central nervous system. These pelvic nerves, they both have a sympathetic and parasympathetic, also have a sensory nerve fibers. And the pudendal nerve, which controls the voluntary controls, which helps in sending signals from the hypothalamus to the autonomous, also the parasympathetic nervous system for the micturition control. So these are the three most important peripheral innervations which help in maintaining the continence. So this is the video animation how the bladder innervation is formed. So we can
To
have a
understand the
clear-cut
micturition
understanding of the
reflex,
bladder.
first we need to understand how the motor and sensory nerves. There are three nerves that you need to remember: the pelvic nerves, the hypogastric nerve, and the pudendal nerve. The pelvic nerves have sensory fibers and parasympathetic fibers. The sensory fibers pick up stretch from the stretch receptors when the bladder fills. The parasympathetic nerves from the sacral spinal cord, that's S2, 3, and 4, they act via acetylcholine on the M3 receptors. That causes contraction of the detrusor and relaxation of the internal sphincter. So the parasympathetic system causes emptying of the bladder. The sympathetic fibers go via the hypogastric plexus from L2 on the spinal cord, and they act on the beta-3 receptors on the detrusor muscle. So it relaxes the detrusor muscle, and the effect that they have on the alpha-1 receptors of the sphincter causes contraction. So it's opposite to the action of the parasympathetic fibers, and sympathetic fibers are responsible for storage. So S for S is a quick way to remember it.
So the sympathetic and parasympathetic, these are the two autonomous nervous systems which controls the micturition. The sympathetic, the major component of sympathetic innervation is a hypogastric nerve which starts from L2 and L3 and which acts on the beta-3 receptors on the detrusor muscles. That sympathetic nervous system helps in the storage, that is, it helps in the bladder filling phase. The parasympathetic nervous system, which runs along with the pelvic nerves, that starts from S2, S3, S4, and which helps in emptying the bladder, which leads to contraction of detrusor muscle, relaxation of internal urethral sphincters, and emptying of the bladder. So, before going to the physiology of continence, we will try to understand what is the basic steps in micturition reflex. The bladder fills after filling of the bladder because of when the detrusor gets relaxed, and at this time the internal sphincters get involuntarily tight, they get closed, external sphincters gets closed, that is voluntarily controlled, pelvic floor supports the urethra, and nervous system maintains the closure of the external urethral sphincter. This is the storage phase of the micturition reflex. But all this helps in maintaining the continence. There is no leakage of urine. But whenever a woman want to pass the urine, when they are ready to void, when the social circumstances are there to pass the urine, brain inhibits external sphincter. So external sphincter, so that so because of this inhibition, external sphincters get relaxed, detrusor gets contracts, and urine flows. This is basic of the micturition reflex in the phase of storage and in the phase of voiding. So an overview of physiology of micturition is that the bladder storage and voidings are coordinated by autonomic and somatic nervous systems. It requires integration of spinal cord, brainstem, and cerebral cortex. So in a storage phase, the detrusor gets relaxed so that the bladder gets filled with the urine, and at this phase the bladder pressure is low and the urethral pressure is high. That's why bladder gets filled with the urine and the internal urethral sphincter gets closed because of its high pressure. So this sympathetic innervation, that is storage pathway, which originates from T11 to L2, that is which runs to the hypogastric nerve. Noradrenaline is the main neurotransmitter to send the signals from the spinal cord to the bladder. These nerves mainly act on the beta-3 receptors, which leads to detrusor relaxation during storage phase, and they also act on the alpha-1 receptors, which are at the bladder neck, which makes the bladder neck contraction, that is, which makes the internal urethral sphincter contracted, closed, and maintaining the continence. So this sympathetic activity, the urethral mucosal coaptation, that means urethral mucosal folds, they get coapted so that the lumen of the urethra gets closed. The pelvic floor tone makes the urethra close. The pressure transmission, that is bladder pressure, is minimum, and the urethral pressure is high, more than the bladder pressure. That makes all the sphincter close, and the guarding reflex. Even at the maintaining the continence, if patient has a sudden cough or sudden sneezing, still the guarding reflex of the pelvic floor helps in maintaining the continence, and there is no leakage of urine. The sympathetic innervation which helps in voiding, that is called as a voiding pathway, and which originates from the S2, S3, S4 and runs through the pelvic nerves from the spinal cord to the bladder. The main neurotransmitter for this parasympathetic signal is acetylcholine, and the main receptors which lies on the detrusor muscles are M3 muscarinic receptors, which are more predominant on the detrusor muscles. The action of this parasympathetic innervation is that it contracts the bladder and relaxes the internal urethral sphincter. The sensory afferent innervation, this is very important, and these are the other than the sympathetic and parasympathetic pathway, these fibers travels with the pelvic nerves to the S2, S3 and S4 the region of the spinal cord. What they do, they convey the bladder feeling and pain. When the bladder is getting filled by urine and it is at that level, they convey the sensation to the brain that the bladder is feeling, and they convey the sensation of the pain to the brain that there is a pain now. You have the bladder have to be emptied down to reduce this pain. So that initiates the micturition reflex. So sensory afferent innervation is also important in maintaining the micturition reflex and maintaining continence in the females. All these sympathetic, parasympathetic, and sensory micturition pathways are controlled by central nervous system. The pontine micturition center, which lies in the pontine, coordinates all these signals coming from the spinal cord and sending to the cerebral cortex. But the cerebral cortex has a final verdict of a voluntary control on external urethral sphincter, whether to release it when the social situation is quite good to pass the urine. So the brain senses that this is the right time because the pain is there, bladder is full, and the social situation is good to pass the urine. So it sends the signals. It inhibits the external urethral sphincter, control over external urethral sphincters, and it relaxes the external. So the parasympathetic system relaxes the external urethral sphincters, and patient is able to avoid the urine. So these somatic nerves, the sensory nervous system runs to this control of this external urethral sphincters from brain to the sphincter is controlled by the voluntary control by the somatic nervous system, which runs through the pudendal nerves from S2 to S4, and the neurotransmitter is acetylcholine, and it controls the external urethral sphincter and pelvic floor. So when the brain sends the signal that this is the right time to pass the urine, the somatic nervous system gets activated, and it relaxes the external urethral sphincters and contracts the pelvic floor muscle to help to void the urine. So this is the video animation of how the physiology of micturition. These are the two videos. Just keep a keen watch on these videos. These are self-explanatory videos that how the micturition reflexes
control of urination. Micturition reflex. When the bladder is full, stretch receptors in the wall of the bladder send nerve impulses to the sacral region of the spinal cord. By way of a parasympathetic response, signals return to the bladder and stimulate contraction of the muscle of the bladder and relaxation of the internal urethral sphincter. This part of the reflex is involuntary and is predominant in infants and young children. As the central nervous system matures, it acquires voluntary control over the external urethral sphincter. Urination is controlled mainly by the micturition center in the pons. This center receives sensory signals from the bladder and communicates with the cortex about the appropriateness of urinating at the moment. At times when it's not convenient to urinate, the center sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder to contract and the sphincters to open to let the urine out. Control of.
So this is the second animation video of a micturition reflex.
So the bladder fills, the bladder stretches, The stretch receptors detect it, particularly at the posterior urethra. The sensory signals go to the sacral spinal cord, back through the parasympathetic fibers, causing contraction of the detrusor and relaxation of the internal sphincter. But the bladder is only partially filled, so the contractions will stop after a while, the detrusor relaxes, and the pressure goes back down to baseline. As the bladder keeps filling, the reflexes get more frequent and more powerful. This is a self-regenerative reflex. Stretch, contract, repeat. After a while, the reflex fatigues. Regeneration stops and the bladder relaxes. Once the micturition reflex gets strong enough, it causes another reflex through the pudendal nerve, inhibiting the external sphincter to relax it, followed by emptying of the bladder. So this entire reflex is an autonomic spinal cord reflex, but it's under the influence of higher centers, the pons and suprapontine centers. The pontine micturition center, the PMC, by default, it tries to trigger the voiding reflex. The cortex has an inhibitory influence on the PMC until the situation is appropriate. So for voluntary micturition, the brain releases its inhibitory effect on the pons. There's contraction of the abdominal muscles, which causes the bladder pressure to rise. The urine enters the posterior urethra under pressure. The stretch receptors get stimulated, followed by the reflex, resulting in the contraction of the detrusor, relaxation of the internal sphincter, and simultaneous relaxation of the external sphincter, causing emptying.
So to conclude, hope the continence is multifactorial. The 5 main things which controls the micturition, and this continence is multifactorial, and it depends on the anatomy, nerves, and hormones. So understanding this continence anatomy and physiology is essential for management, because when we diagnose a case of incontinence of urine, you should know there might be the problem at any point of this 5 supports. It may be a problem at the brain, it may be a problem at the bladder, spinal cord, it may be problem at the bladder neck, or it may be a problem at the detrusor. So we should know the anatomy and physiology of this continence mechanism. Then we can treat a right person with the right management. So I humbly seeking your support and blessing for the post of Chairperson Vaginal Surgeries Committee, FOXI election year 2026. Once again, I thank all the organizers, especially Dr. MC Patel sir, and I wish him all the best for his forthcoming FOXI presidential election. Thank you very much. Over to you, Monica ma'am.
Requesting the chairpersons to please give their opinions and their summation of the talk. Dr. Anil, fantastic.
Thank you.
Hello. Anyway, I don't know whether the chairpersons are there. I think.
No issue. Anybody of us can take over. No issue.
It was an absolute wow presentation. Absolute wow. I loved your videos, and it was so simple and yet so lucid, and I get fantastic things coming up on the screen, and yet so informative. Dr. Anil, you've really done a wonderful job with this presentation, and we hope to see this presentation many, many more times in the near future. And all the best for your campaign. Dr. Anil, we hope to see you as the next vaginal surgery chairperson.
Thank you, ma'am. Thank you. Obliged.
We met during the Vistrit presentation. I am from Bokaro, and we met during the Vistrit presentation. You were one of our assessors. So it's been a long association since then. Moving on to session 2, session 2, we've had a wonderful round about the anatomy and the physiology of micturition, and that is essential to understand how to manage stress urinary incontinence, because that is what exactly our second talk is going to be. And to chair this session, we have three eminent chairpersons. Dr. Krishna Pawar, the past secretary of Parvani Obs and Gynae Society. Dr. Vinayak Khedkar, could we have the screens? He's a past president of Aurangabad Obs and Gynae Society. He's the past chair, Practical Obs Committee 2012 and 2004 to 2014. He has been the past peer reviewer of Foxy Journal. He's been a member of number of committees of Foxy, like the YTP committee, the Food and Drug Committee, the Adolescent Health Committee, Imaging Committee, and the HIV Committee. His hobbies include acting, singing, and yoga, and he loves traveling. So he's a very multifaceted personality. The third chairperson for this talk, Dr. Ramesh Ahuja, has been the past president of Parvani Obs and Gynae Society. And I now request any of the chairpersons to please introduce our eminent speaker and yet another brilliant and very learned person on the same topic, Professor Dr. Vineet Mishra. Any of the chairpersons could please do the same.
Hello, good
Dr.
evening.
Krishna Pawar, yeah, please unmute yourself, Dr. Krishna Pawar, you're muted. Yeah.
Hello, everyone. We welcome Professor Dr. Vineet Mishra, sir. He is Director at Advanced Gynecology and Fertility, Apollo Hospitals, Ahmedabad. He was Director, IKDRC, Ahmedabad, the largest public sector multi-organ transplant program in India. He is pioneering work in Gujarat Dialysis Program, largest public sector dialysis network in India. He has underwent training at University of Petersburg, USA, and Seoul National University, South Korea. He has done research in the field of stem cells, pelvic organ prolapse, and SUI, and female sexual dysfunction. Sir was the Vice President of Foxy in 2016. We welcome Dr. Professor Vineet Mishra, sir. Sir, please have a few words on your topic.
Sir, am I audible?
Yes, you are audible.
I am trying to share my slides. I don't know what has happened to my video.
At the bottom, there is share button.
Yes. This is what I am trying to, Manu bhai, do that. And
Sir, I think now you can share. You were not the co-host yet.
okay.
Yes,
Now,
Nita, but it's your screen, it is being shared. Or is
screen
it
is seen. You select your topic.
is it?
But this is showing Nita's screen.
Yes, that is my wife's
Okay, fine.
laptop.
Fine. Great. Yeah, the screen is visible, sir.
Screen is visible.
Yes, sir.
Okay.
The computer screen is visible, sir, which is showing your multiple videos, and it's a computer screen which is visible, sir. It's not the PPT is not visible, sir.
Is it? But because I have just opened up my PPT and now
Sir, first, before sharing, you have to actually put the slide share down, escape it. You have to do the whole process all over again.
it shows me you are screen sharing. Should I do stop screen
Yeah.
sharing?
Please stop share and then share it again. First, you have to close. So first, please do not open this screen share option in your presentation right now. You have to do it after you share the screen. Otherwise, it will not open in the share screen.
Okay, ma'am. I am little now. I have. Is my presentation visible?
Yes, now it is visible. Now you can do the shares presentation mode.
Now I can go and do the presentation. Just a minute. It is.
Yes. Slideshow.
Is it?
Now, yeah. It is visible, sir.
Okay, it is visible. Some or the other, the video, this is my video is not there here. It is already there, but it on screen it is showing this. It is showing across is there on the camera. I don't know, but I am audible, na,
You
madam?
are audible and your screen is also audible.
Okay. Now, thank you, everybody. Thank you. If madam is still there, then my pranam to madam. She is such a senior person, and all my friends are there. Pandit is there. All my friends from Maharashtra are there. My single appeal to all of you is that Manu Bhai is my senior. He is gem of a person. He is good at heart, and we need people in Foxy who are good at heart and not very foxy. Foxy means वो वाला foxy अपना association वाला नहीं. FOXY वाला foxy. Am I understood? कुछ बोलो. People, hello, am I audible?
Yes.
Yes, sir, you are
Hello.
audible.
Yes, sir.
Okay. Okay. So, thank you, everybody. Thanks, Manu Bhai.
Yes, welcome.
The anatomy and physiology was taken by Anil, which was excellent. And he has put in a huge effort.
Thank you, sir. Thank you.
What
Thank
will I
you.
do is, Anil, fantastic thing. You should win. One of these days, I'll come to Nanded. We have Mangesh there, and we were chairman Urogynec committee. After me, Mangesh became the thing. So one of these days, I'll come to Nanded and learn vaginal surgery tricks and things from you. Yes. So, friends, what stress urinary incontinence, as all of us know, is involuntary loss of urine on effort or physical exertion or sneezing, coughing, activity related. These are the Ayuga and International Continence Society terminology which has been done. Friends, SUI is very common. We as gynecologists are the people who need to bring this thing out from the patient by asking a simple direct question in your OPD, that whether do you leak if you cough, if you lift weight, or if you laugh. You will be aghast. There are a lot of people, almost 10 to 12%, 15% of your OPD patients will say yes. There is a lot of methodology to deal with this. Early SUI, you need to do physiotherapy, then it would come medical. But the ultimate management of an SUI, which is bothersome, which leads to some amount of effect on the life of the patient, then a simple operative procedure can cure her. Believe me, these are one of those surgeries which basically leads to a satisfactory small procedure, daycare procedure, can be done under local anesthesia. Patient is never admitted, and till what age you can do up to any age, because every female has right to live a leak-free life. Age doesn't matter. So, friends, stress urinary incontinence would affect to almost 30-35% of women. For women who fail or decline conservative management, there are eras of surgical procedures that could be done. And what I am going to highlight today is that there are simple surgical procedures that could be done, that could be learned. And we had taken up a mission since I was director of the institute for last 6 years of my 36 years of service at IKDRC. I was little cut off from Foxy and was not traveling. Now government decided that I have to retire, so I got retired and took up a thing at Apollo Hospital, Ahmedabad. We will, once Manu Bhai becomes the president, Manu Bhai will promise that we will go to society by society, me, Hara Patnaik, everybody, and individually teach people by hand holding. So there are more than 200 surgical procedures which has been designated or have been tried. The choice of surgical procedure depends on the number of factors, which includes presence of bladder or uterine prolapse, severity of incontinence, and surgical experience in performing specific type of surgery. Somebody's mobile is on. Somebody's mobile is on, which comes during this presentation, which is what is currently not preferred. Anterior colporrhaphy along with Kelly's plication, 38% treatment failure. Friends, when we were doing our residency, Kelly's plication with AP repair or vaginal hysterectomy was routine, and it was supposed to take care of all the incontinence that happened to the patient. 38% failure rate, 50% by the end of 1 year, and almost 100% by the end of 2nd year. So Kelly's plication is a procedure that should not be done. Keeping incontinence surgery. Second is transabdominal paravaginal repair, which it was supposed to also take care of the urinary tract leak, and it was about 20 to 57 failure. Transvaginal needle suspension like Pereira, STEMIs, RAS, GIDS. These needle urethropexy, very higher SUI recurrence, treatment failure rate, even after 1 year of follow-up. Meaning, when I learned, friends, I had a unique setup. I was as a gynecologist in a kidney institute amongst urologists. So I learned female urology way back from 1989. And something happened that my corresponding urology unit never got SUI surgeries or fistulas to operate. And they always came down to my department to learn these procedures because all those things were tackled by us. So female urology or pelvic floor surgery, my dear friends, is prerogative of us. It is not a prerogative of urologists. Believe that. And these are simple procedures which needs to be learned. I'm sure many of you would be doing it, but these are simple procedures which needs to be mastered. And if societies, they keep surgeries, will come there and demonstrate and do hand holding and teach. Let us go and elect MC Patel. So I'll take a promise from MC Patel that at least in Maharashtra, MP and Rajasthan, we go across society by society and teach them how to do this simple procedure. What is the retropubic suspension procedure? Principle is elevating, fixing bladder neck and proximal urethra to a retropubic position and to enhance the support. Birch-Colpo suspension, which was used as gold standard, which was compared to newer surgical procedures for SUI. Friends, open Birch-Colpo suspension is the gold standard for SUI surgery. Difficult to learn, little lengthy procedure for us as gynecologists going into the space of rhesus. When we were studying, it was almost an impossible imagination to do that. The newer generation, they are doing it laparoscopically excellent. Laparoscopy and open birth scalpel suspension needs a big learning curve. All the other daycare surgeries or mid-urethral tape surgeries, either retropubic or transobturator, are compared with colposuspension. Minimal invasive mid-urethral slings are now considered to be standard surgical management for SUI, since the procedure can be performed as an outpatient basis with local anesthesia, short intraoperative time, and minimal amount of dissection. So what are these procedures? They are TVT, or tension-free vaginal tape procedures. TVTO is the obturator procedure, and TOT again is the obturator procedure. TVT and TVTTO are the nomenclature of the device from J&J, and the remaining transobturator devices or prostheses, they are known as TOT prosthesis. Factors influencing the choice of primary surgical procedure: coexisting of treatable pelvic prolapse. Then medical morbidity and functional status of the patient, experience and technical skill of the surgeon. Should an SUI procedure be performed with the prolapse procedure? Does surgery of prolapse leads to SUI? What are these? Any medical condition, morbid patient who has a leak, can this surgery be done? Answer is yes. Friends, when there is a prolapse, you need to put the prolapsed organ in its anatomical position and perform a cuff test. If it leaks, then after you have done a corrective procedure for prolapse, please go ahead and do the incontinence treating procedure, or at least inform the patient that once your prolapse gets treated or gets operated, there is a chance that you might leak. This is a pre-existing condition which is there. Either it is done simultaneously or it is deferred and done after 10 days or 15 days. Now, what is tension-free vaginal tape? Friends, the 200 procedure plus which are there in the literature, majority of them, these procedures were fixed either to the symphysis pubis, back part of symphysis pubis, or somewhere around the rectus. All those procedures had a big failure. So when tension-free vaginal tape concept came from Armstein, the Swedish scientist, they found that if the tape is left unhooked to any of the organs, it just lies at the level of pubourethral ligament, and this tape will ultimately lead to a successful procedure and cure the incontinence which is happening. Tension-free vaginal tape was devised by Armstrong, synthetic polypropylene mesh, macroporous mesh, around 14 inches in long, which has a serrated edge. Why it has got a serrated edge? Because they act as anchors and go anchor inside the connective tissue and along the muscle through which it passes. TVT basically was a retropubic system. It is a retropubic system. Preparation, as you know, the normal preoperative preparation consent. The urine has to be sterile, friends, because if you do a procedure in a culture positive urine, then this infection will flare up. Then we have an issue. Dorsal lithotomy position, GA or LA. If it is LA, it is xylocaine with adrenaline, which is there. Normal saline around 50 to 100 ml is also used along putting it in the retropubic space. Empty, you just need to put in a Foley's catheter, empty the bladder, and a mid 2 centimeter vertical incision at mid urethral area is done. It is dissected, and with the help of what you call with the help of your guide, this tape is put in. Here lithotomy position is done. You will see that an incision is put in. If you see the video again, what we have done is, here is the pubic tubercle, which is felt on the edge of symphysis, at the edge of the pelvic brim. 1 finger above that and half an inch incision lateral to the pubic tubercle is put in. You can infiltrate normal saline, you could infiltrate adrenaline and xylocaine there, around 10 cc each. Give a small incision and then put in your index finger there, palpate the rectus there, and and palpate the rectus there. And now what you do is, in the lithotomy position, what you will do is, there are, by the side of urethra, there are 2 sulci, which needs to be caught with the help of Ellis, and a mid-urethral line is drawn. It could be infiltrated, and then this is basically a prosthesis called TVT or elevate. This is the elevate prosthesis, which is basically a retropubic procedure. Here you put in, and then what you do is, you do it on both the sides. You point it towards the ipsilateral shoulder, the same side ipsilateral shoulder, and then adjust the tension. Here, I'm sorry, we missed the thing. So now what you do is, you put in a curved dissecting scissor between the urethra and the tape and adjust the tension. Here, after you have put in the retropubic needle, you need to do a cystoscopy and look for the needle passing through the bladder. In case it passes through the bladder, please don't worry, remove it, go little lateral and complete the procedure. Let us see this video till end. Here the tension is done, and once this tension is put in, the plastic cover is removed, the mid-urethral thing is sutured with 20 Vicryl, and the upper thing is also, the anterior abdominal wall thing is also closed with 1020 Vicryl. These are the steps. Friend, this is the needle that is coming out through the bladder. Once it comes out through the bladder, don't panic. Remove it, go little lateral, empty the bladder and go little lateral and complete the procedure. This small 3 millimeter or the older prosthesis, which was about 12 millimeter needle, all those will automatically heal and no fistula would be formed. What was happening is, retropubic procedure, cystoscopy, 20, 30 years or 30 years back when we started demonstrating, there was a lot of resistance from the gynecologists telling that cystoscopy they will not do or they didn't have equipment. Now, because there is endoscopy everywhere, so the hysteroscope 2.9 mm or a 4 mm hysteroscope is the thing which then you just need to buy you just need to buy a cystoscopy sheath and you will be able to do a cystoscopy. Simple procedure. Transobturator is the procedure where the bladder doesn't come in. The urethral, you will see the anatomy. This is the way the transobturator tape could be put in. The obturator anatomy, this is basically the rim. This is the symphysis pubis. This is the insertion of adductor. These are the obturator canal which is there. This is the insertion of adductor longus. And this is basically the area through which the needle will pass from one side to the other side. Obturator canal is pretty far away, and obturator canal has vessels and nerve there. It is quite far away, and the chance of injury to the neurovascular bundle is almost negligible. Here, if you see, what we have done is, we have caught hold of the two sulci which is present in every female. You'll be able to appreciate that in lithotomy position. Catch hold with the help of Ellis, and then palpate the Follis bulb. The upper end of the Follis bulb, which you have filled it up with 10 cc fluid, the length of the entire urethra will be appreciated, and then what you need to do is put in a mid-urethral incision. You have just, I am injecting normal saline, putting in an incision, now putting in a curved dissecting scissor, which basically goes towards the safe entry zone, opening up, and now these are the markings of adductor longus. And now what I am doing is, these are the earlier needles which we had devised, which is put in and pushed with the help of the thumb. Your index finger is lying at the inside the incision. You will be able to feel the tip of the needle, rotate, and it comes out. Needle has an eye at the tip. You put in the tape and then rotate it counterclockwise and it comes out. Friends, this was the innovation that we did at Kidney Institute, and the expensive J&J prosthesis. The cost was brought down to about 800 rupees. These prostheses are the Freedom prosthesis available from Lotus, and that prosthesis is known as Freedom VM. VM stands, they gave that VM on my name because that was our innovation from Kidney Institute, Ahmedabad. The opposite side, this is done, which is the tape is locked there. There is a small point there which helps you to lock it and rotate it counterclockwise. And now you just cut and free the needle, put in a curved dissecting scissor there and adjust the tension, remove the curved dissecting scissor, then don't pull anything, close the anterior vaginal wall incision, cut the two lateral ends of the tape which are coming out through the skin in a way that it falls below the skin. Take single bite, put in a waterproof dressing there, and the patient is ready to be discharged. This is a prosthesis which is TVTO, which is basically an inside-out procedure. What you saw initially was the outside-in procedure. The sulci both the sulci are taken off with the Ellis, and mid-urethral incision is put in. And then what you do is, there is a guide which is available. This prosthesis, now there is a prosthesis from Myril, which is similar and inside-out procedure. We are demonstrating that at Bhopal IMS conference happening on 27th of this month. These are two needles. Through the guide, you just push in, and once you give pressure, it comes out from the incision, which was predetermined, put into the obturator area. Now you remove the guide. With the help of cockers, you catch hold of the tip of the plastic thing and remove the, see here I have got hold of that, and I have removed the SS which is there inside the plastic. We are cutting it. Same way it is done at the opposite side. Here, the thing is, this prosthesis has a small tag which is there in the center of the tape. So here you will be able to adjust it much better as compared to the Freedom VM, because it doesn't have such a type of tag which is available there. Once you have adjusted the tension, you need to cut and remove the tag, remove the plastic covering, and then what you simply do is, see again here, the prosthesis is being put. There is a guide there, and you simply push it, and it will come out from the predetermined incision area. Here, now catch this with the help of an artery or a cockers, and now you just need to put in a curved dissecting scissor. Here I am pulling the tag, and there is a prosthesis which is called TVT Abrio, where the tape is only half the size in length, so lesser amount of synthetic material remains within the body. Friends, this dotted line shows the TVT, and the solid line shows the TOT. TVT is excellent for interstitial, for intrinsic sphincter deficiency, meaning when patient is in lithotomy position with full bladder and you ask her to cough, lot of urine comes out but doesn't spurt. It doesn't go and hit the opposite wall. It just falls into the bucket. That is the easiest way to determine the intrinsic sphincter deficiency. TVT is an excellent prosthesis. Retropubic prosthesis is excellent for this type of patients. Rest, when it spurts, there is mid-urethral hypermobility. As Anil sir had already pointed out in the physiology, there a transobturator procedure is good enough. So here, the second slide, you see the natural pivourethral ligament, and the other thing is the prosthesis that we have put in. So there are cases in retropubic. There were bowel injuries were there. There were injuries to the vessel. Bladder injuries were there. Retention was there in early cases because they deviated out of the anatomy. Complications, they were basically erosion was 3 to 5%. It happens in both retropubic as well as in transobturator procedures, because it is usually in the midline, because the postmenopausal mucosa is very thin, or in early times when you are afraid that you might slit open the urethra, you take a very little amount of anterior vaginal mucosa. So in that case, don't worry, you just need to take the patient inside, put it in lithotomy position, sterile drapes, take xylocaine, adrenaline, about 10 cc in syringe, 20 gauge needle, and push it between the mucosa and the exposed prosthesis, put in a curved dissecting scissor, dissect out open, and then wherever you find that there is a good thick tissue, go little ahead and put in a Z type cut, pull that tissue in center. You will find that tension free, this tissue will come in the center, suture it with 1020 Vicryl, and the Z incision which you had put in, the Z plasty, it becomes straight line. You can close it with the same amount of the same Vicryl or chromic catgut. Advantage of TVT over TOT over TVT, it is rapid, low risk, easy to learn. It avoids retropubic scarring, reduces bladder perforation rate, and TOT doesn't need cystoscopy. So there is shorter learning curve, it is safer, cost effective because it is very widely used. So the cost of that prosthesis is less as compared to retropubic. There is huge amount of literature which compares that TOT and TVT. All of them match the gold standard of Birch-Colpo suspension. We have excellent laparoscopic surgeons now, the younger generation. They are doing marvelous job, and they do a lot of very good retropubic Birch-Colpo suspension. The only disadvantage of Birch is during your learning curve, if you have tightened it, and there is retention, then you need little expertise vaginally to cut that proline or proline non-absorbable material vaginally. You don't need to again do a laparotomy and go retropubically and cut and loosen the thing. Suppose Birch fails, you go for a retropubic procedure. If retropubic fails, you go in for TOT. After every failed procedure, get a urine culture done, get a urodynamic done. That is the time urodynamic becomes compulsory. Choosing a patient who is diabetic, who has diabetic cystopathy, or is continuously dribbling. If you are trying to do any one of these procedures and trying to free her from wetness, there will be a failure. You need to counsel the patient. We have done a tight retropubic procedure where there is almost occlusion of the urethra, and then we ask these patients or their relatives to do intermittent catheterization, and patient remains dry. The wetness goes away, but intermittent catheterization would be needed. There are registries which are there. Indian registries are not there. There is a big population studies which have been done, which is basically everything trying to say that incontinence could be very easily treated as an outpatient procedure, and a simple procedure that gives satisfactory result. Cochrane database is also there, 2014, which is there. There was a lot of anterior prosthesis, anterior repair, means cystoplasties were done using mesh. They were apogee and perigee prosthesis. We had done it, but there was a lot of erosion. Ultimately, on international scenario, these prostheses are now removed. There are meta-analysis done. This was very early studies which is there. These are the Freedom VM tapes which are now very widely being used. We had excellent results. So to conclude, when we compare TVT and TOT procedure in terms of continence, complication, and quality of life, No significant difference between these two procedures were there. TOT cure rate was observed around 78% and 81% for TVT. Quality of life improvement was excellent in both the cases. Thank you very much for patient listening. Unfortunately, my video and camera did not function, but since slides and everything was visible, I'm thankful to the organization and I'm thankful to Anil and all my chairperson. My request to all of you, please go ahead and have MC Patel Manu Bhai. Manu Bhai is, I shouldn't be saying, but he is the person who basically has an RSS background, very ethical person, very committed person, and I'm sure clean person and will lead Foxy to a different level. Thank you very much, chairpersons.
Thank you. Thank you, Vinit Bhai.
Thank you, Dr. Dr. Vinit Mishra, Professor Dr. Vinit Mishra. I would request the chairpersons to please speak a few words and sum up the session.
Madam Nivedita, tell me by keeping your right hand on the heart that there were people listening now, because otherwise there was no response. कोई बोल ही नहीं रहा था. So I was...
we are listening, sir.
Is it, madam?
Sir,
I thought at the end
sir,
of the...
one question is there.
Tell me, Savita.
Sir, nowadays in cosmetic gynecology, we taught that high-fem chair and threads and PRP.
कुछ नहीं होता है.
Does
कुछ
it
नहीं
really
होता है,
works
सविता.
in stress urinary incontinence?
सविता, कुछ नहीं होता है. उसको बैठ के एक बार फिजिक्स देख लो. मेरे साथ और नीता के बीच में झगड़ा यही होता है. वो कॉस्मेटिक करती है, मैं यूरोगाइनिक करता हूँ. एंड आफ्टर द कॉस्मेटिक थिंग गेट्स ओवर और 3-4 महीने के बाद पेशेंट आता है ना वापस, it doesn't happen. Okay. Nothing happens. Every claim which is done by cosmetic machinery selling people. Madam, imagine the pubo-urethral ligament is weak, there is hypermobility. How will anything, any PRP, anything, Emsela chair, or I have Thermiva. Okay, we did a multinational trial for Thermiva, madam, 5 years back, along with Ajay Rane.
Okay.
And Sejal, but nothing works. I will, madam, आप मेरे को भेजना, मैं वो जो हम लोगों ने मल्टी 8 आर्म स्टडी किया था ना, वो मैं आपको भेज दूंगा. वो कॉस्मेटिक वालों को नहीं मजा आती है if I send them across.
So rather than going for this difficult surgery, should we try? और
मैडम 5 मिनट की सर्जरी है. आप 5 पेशेंट अपने यहाँ रखो, मुझे ला दो वहां पे, एक टाइम अच्छा खाना खिला देना, मैं आपको 5 सर्जरी में 6ठी आप करोगी.
Okay, sir. Okay, sir. Thank you so much.
Yeah, thank you, Savita.
Dr. Vinit Mishra, sir, very nice lecture, very nice speech to hear from you, very senior person. But we have seen only this topic, rare topic, to say on the grounds only in the conferences. We have not been taught in the curriculum previously. Nowadays,
yes, sir, we are not taught in our curriculum. Yes.
Madam, अरे रमेश, अरे रमेश जी, एक काम करो, आप जो सोसाइटी में ना उसमें रखो. एक तो सबसे पहले मनु भाई को ले आओ प्रेसिडेंट की तरह. Then I will catch hold of मनु भाई के 52 live operative workshop has to happen. Manu bhai, do you promise that, na?
Oh yes. Oh yes.
Savita madam.
Yes, sir. These surgeries are not taught in our post graduation, sir.
ऐकून घ्या, आपल्याला घ्यायचं कॅम्प.
Yes, sir. Yes, sure, sir.
हर एक मेडिकल कॉलेज में रखो ना, उसमें कोई लाइव ऑपरेटिव वर्कशॉप दिखाने की जरूरत नहीं है. हर एक लोगों को आके हैंड्स ऑन कर देंगे. खाली एक ही चीज है, अच्छा मराठी खाना खिला देना, बस.
Yes, sir. Yes, sir. Sure.
I remember sir had come to Bokaro and he had done the same training with Dr. Hara Patnaik and Dr. Professor Vineet Mishra had come and they had done that. And after that, we had quite a few surges of people doing TOTs. And now again, it's gone down.
Madam, Navedita, मेरे को है ना, I have a disease.
You need
I suffer from a disease which is called hand and mouth disease.
to come.
हाथ में जो आता है मुंह में जाता है, हाथ में आता है मुंह में जाता है. I keep on eating. So I'll come there. Some Marathi societies have to give me a good Marathi lunch or dinner.
Definitely.
And everything is taught.
Yes, sir,
हर एक
sure.
लोग दो दो पेशेंट लेके आओ, मैं आऊंगा, मनु भाई को साथ में लाऊंगा और
जरूर. Dr.
ऐसा
Patel
है.
has promised me to come to
Oh, yes.
Parvani
Yes, yes.
before the elections. Yes.
Yes.
Again, one word regarding sir. He is Dr. Patel is the master of masters. He is, I think, Amitabh Bachchan of the Foxy academics, and we wish very big success for the forthcoming election.
अरे रमेश
Yes, sir.
जी, let me correct you.
Yeah.
वो मनु भाई अमिताभ बच्चन नहीं है, वो राज कपूर है, राज कपूर. वो राज कपूर है ना?
Showman.
Okay, okay. Right.
Thank you very much.
Thank
Thank
you.
you,
Thank
Manu
you.
bhai. Thank you,
Yes.
Ramesh ji.
Thank you, sir.
Nivedita, thank you.
Thank you, sir.
Oh, yes.
Thank you, Savita.
Nivedita, proceed further.
Yes, sir. I now thank you for the excellent deliberation, and we've had two such excellent deliberations. Moving on to the third session, I would request the coordinators, Dr. Monica Umarban, to start over the next session along with the third coordinator.
अरे Ajay is there क्या? Ajay Mane is there. अरे good.
He's not yet joined, sir.
Okay. Supriya is there. Archana is there. Oh, yeah. Manu bhai is doing good thing. He's having all. He's making me go in my flashback.
Can I have surgical yes,
We will proceed with the third session. After that very inspiring talk by Vineet sir, we have two more academic sessions left in this discussion. The third session is a talk by our very own MC Patel sir on medical legal issues in urogyne practice. We have three chairpersons with us, Dr. Ajay Mane sir, Dr. Supriya Pandit ma'am, and Dr. Archana Saraf ma'am. Dr. Ajay Mane sir has been the vice president of Foxy as well as the past president of Aurangabad Obsgyne Society and past joint secretary and past chairperson of Adolescent Health Committee of AMOGS. Welcome, sir. Our next chairperson is Dr. Supriya Pandit ma'am. Ma'am is the consultant and CMO at NWC MC Mahapalika, PCPNDT MTP Nodal Officer as well. Welcome, Supriya ma'am. And we have Dr. Archana Saraf ma'am with us. Ma'am is the president of the Hingoli Obsgyne Society with a special interest in colposcopy and has been the past secretary of the Hingoli Society. Welcome, Archana ma'am. I would request Archana ma'am to kindly introduce MC Patel sir. Archana ma'am.
Is she there?
She's there, sir. I can see, ma'am. Because I cannot see Supriya ma'am and Ajay sir. I will go ahead, sir. We'll take her comments later then, sir.
Oh, yes. No issue.
Yes. So our very own MC Patel, sir, he is the medical legal counselor, as very aptly said, master of masters. Sir has been, highlights of sir's life has been, he has been very instrumental in having consents, uniform consents in various departments of Foxy. He has been medical training, has been conducting medical legal training and support for the members, has been the vice president of Foxy in 2018, also the chairperson of Medics and Ethics and Medical Legal Committee and the organizing secretary of the AICOG 2017. He has various government roles to his credit, and I don't think so he needs any introduction. He is known by everyone. Wishing him all the best. Sir, over to you for your talk, sir.
Yes. So please allow me to share my screen. Is my screen seen?
Yes, sir.
Yes. Is it full screen? Is it full screen?
Yes, sir. Yes.
Yes, sir.
Okay.
Yes, sir.
Okay. Fine. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar, Aurangabad, Parabni, Nanded, and Hingoli, and President and Secretary of respective society to this webinar. I again thank you all because during my election campaign last time, you stood with me just like a rock, though I lost. But I believe in this. It was nicely written by Shraddhe Atal Bihari Vajpayee, and I was lucky to work under him. क्या हार में क्या जीत में किंचित नहीं भयभीत में करते हुए के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end, but new beginning, and journey to serve Foxy still continued with renewed patience. So my commitment is still there. Whenever you are, I'll be there. Promise to reach the unreached in any odd medical legal situation. So I'll be seeking your blessings again for the same post, President Foxy, election year 2026. And today's topic, urogynec practice and legal consequences we are going to discuss. Usually I start any of my talk with this question, is it worth discussing? Yes, and if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. And of course this is in Gujarati, but it is written like this. As such, I have searched in Google about my illness and related medicine and management, but I thought, let us have a second opinion from you. So this is real scenario nowadays in our day-to-day practice, and ignorance of law can never be an excuse, because as soon as any act, any law, any ordinance passes in government gazette, it is presumed by law that each and every citizen of India knows that law. So ignorance of law can never be an excuse. As far as urogynecology is concerned, it is a subspecialty of gynecology. And if we go with this list, I do not want to go into detail, but incontinence, nicely discussed by Dr. Vinit Mishra, and previously anatomy and physiology by Anil Sakre for incontinence. So types of incontinence: urinary urge incontinence, urinary stress incontinence, mixed incontinence, overflow incontinence, functional incontinence, reflex incontinence. And as far as prolapse part is concerned, one more area in urogynec surgery: anterior compartment, middle compartment, the uterine prolapse or wall prolapse, and posterior compartment. So we are dealing with this type of conditions in our day-to-day OBGYN practice. So there are certain situations during this practice, and we may go end into litigation, and there could be common allegation before us. Face litigation and pay compensation because it was delayed in diagnosis, investigation, or treatment, missed diagnosis, investigation, or treatment, wrong diagnosis, unnecessary investigation. Nowadays, due to fear of this CPA, naturally we go for certain investigation, and it becomes expensive to the patient. So many a time this allegation also comes during litigation, that it was unnecessary investigations, no proper consent, staff was not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all we have to transfer patient to any other center, and if it is delayed, then it also becomes one reason for litigation. Complications related to our urogynec practice, like complication of anesthesia, failure of procedure or operation, very nicely covered by Dr. Vinit Mishra, TOT, TVT. But if at all any procedure in urogynec practice fails, then also it becomes a area for litigation. Hemorrhage, naturally very common condition. Infection, trauma or injury to nearby structure during this surgery: ovary, urinary bladder, ureter, blood vessels, and bowel. So whenever we are facing any complication related to this, it becomes an area for litigation. And naturally, when patient end into morbidity, then also it becomes a area for litigation. Mortality, of course, in urogynec surgery, mortality is very rare. But if at all it happens, then again, it's area for litigation. Overcharging, nowadays, this region is also coming up, and this is a very common allegation. Tremendous expense against unexpected result. And if patient has asked for record, and if we have refused, then this is also one more allegation, ask medical record and not provided. And failure of patient to comply with schedule follow-up, this is also one more area. But in this situation, it becomes good defense in our favor, because if patient doesn't comply our instruction, and if he fails for follow-up visits and further treatment, then it becomes a contributory negligence on part of patient, and it becomes a good defense in our favor. There are certain alarming situations. We should be alert in this type of situation. Patient or relatives dissatisfaction. If they are not satisfied with our approach, our result, then it becomes an area for litigation. Asking to take second opinion if you have refused, because many times few of our friends have a way of working. I am the only consultant, but never do this. Whenever patient is interested to go for second opinion, let her go. Or you manage also, I would say, for second opinion. Asking to shift patient to another center, and if you have refused, and death of young patient, just I mentioned, of course it is very rare, but if at all it happens, then it becomes area for litigation. Let us say this is real happen case in state of Gujarat only. Patient at Veraval, which is nearby famous Somnath temple, was operated for TLH. After 21 days, developed incontinence of urine. So VVF was confirmed, and patient was referred to Institute of Kidney Disease at Ahmedabad, where Dr. Vinit Mishra was director since years together, and he had put that very institution at a much higher level. So in that very institution, this patient was referred, but patient refused to go to Ahmedabad because patient was from Veraval, and it was long distance to travel to reach Ahmedabad. So again, patient was referred to Rajkot, but in Rajkot Civil Hospital, there were no neurosurgeon, and patient ultimately went into private. VVF was repaired in private, and in this case was filed, notice was served. Allegation was there was carelessness on part of treating doctor, deficiency of services, injury to urinary bladder during TLH, and at Civil Hospital Rajkot, doctor told that there is big injury and better you go to expert in private hospital. And here there is no expert, so we had to go for private hospital, which was beyond our reach, beyond our capacity to go for expense, and expense was beyond our capacity. So these were the allegation in this particular case, and compensation was demanded rupees 20 lakhs. I was legal counsel for this gynecologist, and we requested Honorable Consumer Fora to invite that very surgeon who operated for VVF, and I was interested to go for investigate him also, but court was not ready to make him available physically, but he was interested to give certain question, and we went with those questions, and we sent all those questions to that VVF surgeon. And very common question I had asked during TLH, to have an injury to bladder, is it common complication, known complication? Naturally, one cannot say no. So answer was yes. So in spite of all care and caution, is it possible that bladder injury could be happen in this type of situation? So again, answer was yes. And it is repairable condition, VVF, yes. And if it is repaired nicely, then there could be no morbidity to the patient, yes. So with this type of question, we could convince court that it is known complication. It can be managed further. Even if patient would have to be us, then we would have advised her to go to a proper place. Of course, we had advised her to go to Kidney Institute Ahmedabad, but patient didn't go there, and patient preferred to go to Rajkot and ultimately in private. So that was choice of patient. But in this case, court was convinced and case was decided in favor of doctor. Let us see one more case, same type of case. In this case, post-cesarean section, continuous urinary complaint, and there was fever. So recurrent abdominal pain and exploration done, and mass was removed from abdomen and sent for HP. And in that very mass, metallic tip of suction cannula was found and case was filed. And in this particular case, inference held by the court was there was negligence on part of treating doctor, because if at all suction cannula might be broken during surgery or so, but tip was left inside and it made all this problem. So compensation of rupees 2 lakhs was awarded in this particular case in favor of patient. So in this case, particular case, res ipsa loquitur, which is a very common doctrine in eye of law, was applied. What is res ipsa loquitur? Evidence per se, or thing speaks itself. So if we can prove that prior surgery was done, and it could be evidence by discharge card, etc., and there was something left inside, foreign body. It could be instrument, it could be just like this tip of metallic cannula. So it can be confirmed by X-ray or radiological examination, ultrasound examination, MRI, CT scan, and after again surgery, it can be removed. It can be sent to a laboratory for confirmation by histopathological examination. So these are the cases sure shot to go. Of course, I am lucky. I defended 2 of our gynecology in those very case. They left mop inside during cesarean section. In both the cases, we won, but these are exception. Of course, whenever we left mop inside or instrument inside or any this type of accident happened, tip of metallic cannula, then it is very difficult in this type of cases to defend this type of cases. So it is always better to go for compromise with the patient. So many times this question is asked, outside court settlement. What is outside court settlement? Of course, many a time people may understand like this, that if you give some amount to patient or patient party and we take in writing that we had been offered this much amount, now there is no complaint, but it doesn't work much in court of law if at all patient files a complaint, because in few of the cases it is found that even after getting some remuneration, patient had preferred appeal or a case in court. So in this situation, we should be very clear, always go for outside court settlement, but of course through court. It is called consent decree. So in court, we will file a complaint that this was the case and now there is settlement between us and amount is also fixed. So court will pass decree. And in this condition, once you have paid amount which is decided by a patient and ourselves in between, and court will pass decree, and then after patient cannot go in court, this court or any other court further for that particular case. So whenever if you are thinking for outside court settlement, even then it should be through court. As far as ureter is concerned, naturally in OBGYN practice, ureter and urinary bladder, there are 2 organs as far as our urogynec part is concerned, and these are the vulnerable part as far as injury or trauma is considered. So Sir Thomas Spencer, he was the president of RCS, and he was the first surgeon to do successfully ovarian cystectomy. And it was his observation that I do not see any mode of certainty providing against the mischance of dividing one or both ureters. So he was also convinced that injury to ureter, single or double, is possible in our urogynec surgery. He further added, I fear that with all possible care, it is an accident which may occasionally be unavoidable. So, in spite of all care and caution, injury may occur. One more legend, Henry Rich, laparoscopic hysterectomy in current gynecological practice, review in gynecological practice, what he has to say. He said, I have always been obsessed with reducing ureteral injuries. Most are not identified or even suspected without cystoscopy. Even if surgeon is visually able to identify the ureters, normal peristalsis may occur in damaged ureter. So he was very clear, even if ureter is damaged, it could have normal peristalsis and we may be misguided. So he was recommending routine cystoscopy after any of this kind of surgery. So would there be any experienced gynecologist or surgeon who has not injured urinary tract at some time during pelvic surgery in his career, just like perforation of uterus in medical termination of pregnancy? So this is very common condition. Trauma to urinary bladder or ureter is very much common. So are ureter injury increasing over the past decade? And there was study by this group. So gynecological procedure, surgical procedure, and urological procedure. So Markin and Toll, they had an observation in 10,110 hysterectomies that ureteral injury with laparoscopic versus abdominal hysterectomy was the study, and it was found that during laparoscopic surgery there were more chances of ureteral injury. And medical negligence claims over 30 years, so it was 70 per year in 1974 and it went up to 5,965 per year in 2003. So it was observation in with this study, and cost over 30 years is 1 million to 446 million pound as far as amount of compensation is concerned. So laparoscopic surgery is more dangerous as compared to any other surgery related to urinary tract injury is concerned. So injury was in most of the cases in lower ureter. It was one more observation. In 89% of the cases, it was in lower ureter. And as far as diagnosis part is concerned, it was delayed in 79% of the cases, with median time to diagnose was 6 days. Because many times what happens, there is thermal injury and necrosis occurs after few hours or 1 or 2 days, and there is sloughing out and then fistula develops. So many times prompt diagnosis is not possible in few of the cases. And urinary tract injury in gynecological laparoscopic surgery 0.3% to 4%, and it was observation that during LAVH it is 0.49% and during TLH it is 4%. So these were some observations as far as our urogynec practice is concerned. And during deciding judgment, there were some quotes on part of judgment also, and it is our observation that now culture of compensation, because patient is interested only to get compensation. So many times merely on very minor complication or minor complaint, they file complaint and we have to face litigation. But in court, this was very common dictum. For every accident, someone is at fault, and every injury, someone is to blame, and for every accident, someone has to pay. So if at all something goes wrong and case is filed, many a times court are in a mind to award some compensation to patient, and nowadays amount of compensation is increasing so high, so we are scared for that also. The risk of injury, especially to ureter, is increased with laparoscopic approach, and urinary tract injury in gynecological surgery commonly ends into litigation. Why? So why these injuries are common in laparoscopic surgery as compared to any other conventional surgery? Lack of tactile sensation, decreased morbidity for manipulation, reduced visual field, depth perception, and panoramic view, reluctance of gynecologists to gain entry into retroperitoneal space, suboptimal knowledge of pelvic anatomy, and reliance on hemostatic energy devices and stapling tool, because stapling tools usually in routine conventional surgery we do not use. And this was one more observation: 67% of ureteral injury due to stapling, harmonic and tissue sealing devices. So this was observation in one of the study by Buggies in 2010. So how do you tackle such situation clinically, ethically, and legally whenever you are facing this type of problem? Role of routine intraoperative cystoscopy. So should it be considered after all this surgery to go for cystoscopy? Should cystoscopy be routine? So what ACOG had told in 1997, at conclusion of any pelvic procedure, both ureter and bladder should be inspected to confirm their integrity. And again, ACOG in 2007, cystoscopy to rule out cystotomy and intravagical or intraurethral suture or mesh, and to check bilateral ureteral patency during or after certain procedures. Those procedures with relatively high risk of this complication, 1 to 2%, may benefit from cystoscopy. So it was recommendation by ACOG in 2007. And in this study, it was one more recommendation: hysteroscopy, a hysterectomy associated urinary tract injury is a preventable morbidity, more palpable in corporate cystoscopy instead of suffering medico-legal action. So it is always better to go for cystoscopy to confirm no bladder injury, no ureteral injury, rather than to face medico-legal action. And in this particular study, so prospective multicentral trial, 479 patients, all hysterectomized, had routine cystoscopy, and there was observation that 100% detection rate as far as ureteral injury is concerned, 94% detection of bladder injury is concerned, and negative predictive value 99.8%, and one injury missed presented with VVF, tissue ischemia, necrosis. And in this very study by Fasolino in 2002, 2 VVF after LH despite normal cystoscopy. So just I mentioned prior also, many times there is thermal injury, and after a few hours or after a few days, there is sloughing out and VVF may happen. Thermal injury to ureter, it is a very common condition in our day-to-day urogynec surgery by endoscopy. So very important question here: whose domain is urogynec? Surgeon versus urologist versus gynecologist. So does training require as far as gynecologist part is concerned? And if you want to go or go for urogynec surgery. So in court of law, it is taken like this: if it is in curriculum of OBGYN, so whichever curriculum is there in OBGYN, you can practice. So how to deal with injury to bladder, how to deal with injury to ureter, if it is a part of curriculum of OBGYN, then one can practice that part also. But it is very tricky situation. So it is always advisable, if urologist is available nearby, it is always better to call him and involve him, because it shares responsibility and it shows your concern to take utmost care of any patient in given situation. So is diploma available abroad versus weekend training program by Foxy or any other institution are enough? So it gives you one more good defense if you are trained in recognized institution, but it should be recognized by National Medical Commission. So one more area: who is an accomplished urogynec surgeon? So if we go by NMC guideline, then person who has MCH in urogynecology by virtue of his degree and registration in NMC, is accomplished urogynec surgeon. But by experience, any gynecologist deal with this type of urogynec surgery if is trained by registered institution and it is approved by National Medical Commission. Let us see one more case. Patient underwent hysterectomy for bilateral TO mass with chronic PID. After few weeks, develop urine leak. This is a very common condition. After hysterectomy, this type of leak may occur. So what is your approach as a consultant in this type of situation when patient comes to you with complaint of leak? Then how will you talk to patient? Naturally, we have to explain her what has happened and which are the remedy further. We have to explain all the remedies available to the patient. And in this situation, one more very interesting situation. Would you like to call surgeon or urologist at your place and to deal with situation, or would you like to refer patient to that very center? Of course, we can discuss with the patient. Ultimate decision would be on part of patient. We can discuss all the pros and cons, whether to be treated or operated at our place or at surgeons or urogynecologist place. Whether do you like to operate specially in hospital versus same hospital. So you can operate your hospital also, calling surgeon or urologist, or you can refer patient to their center also. Sorry. Would you ask consultant to come to attend your surgery? Because many a time during surgery also we may require. So do not hesitate to call them. If they are available nearby, always involve them. It shows your interest to be helpful to the patient in that very given situation. So in this particular case, underwent another surgery for VVF repair, and that VVF repair was failed again. And in this particular case was filed. So negligence was alleged on both gynecologist and that surgeon who joined gynecologist to repair VVF. So in this situation, how do you counsel patient pre-operatively and possibly post-operatively? Because pre-operative counseling, of course, we do. But in this situation, whenever we are dealing with any TLH or any other urogynec surgery, then in this situation, all the probable complications we have to explain to the patient. And very important part, if at all we meet with any complication, of course, we can deal with accordingly during surgery, but post-operative counseling is equally important. And we have to counsel patient for that also, what has happened, what we have done, and what could be the consequences in future. So if we have convinced patient that way, then it becomes easier for us to face in court of law. What is law regarding documentation? As there is no specific law regarding documentation, but whatever we have counsel post-operative, it should be well documented, which question patient has asked, which were answered on our part, and whatever thing we have explained to the patient, we have to mention in that very paper. Sorry. So let us see one more interesting case. It was vaginal birth after cesarean section. Forceps was applied and ultimately it entered into utero-vaginal fistula. And case was filed. An expert opinion from commissions was asked by the court, and there was opinion like this: was avoidable if opposite party was careful in applying forceps. So this type of very casual comment or loose comment may be troublesome for person facing litigation. Of course, we can challenge this type of comment in court of law also. Court always allowed challenging this type of case. But in this particular case, negligence was proved in court of law, and compensation of 12,500 was awarded with cost in favor of patient. So how do you tackle such in consumer court whenever you are tap into this type of situation. Value of expert witness. If patient put expert witness on her part, we can also invite expert witness requesting honorable commission or court, and many times court is pleased to allow expert witness in our favor. Also, I have also appeared so many times in court as an expert witness, so we can call expert witness in our favor. So in this particular case, State Commission dismissed the complaint. Appeal was filed by patient. National Commission observed that both the surgery were performed with due care. There was no carelessness or negligence on part of treating surgeon during first surgery and at the time of second surgery. No complications at the time of discharge and problems not related to surgery and no medical negligence. So ultimately case was decided in favor of doctor. So would you appear from the commission side for opinion against doctor? $1 million question. Because in my practice, I have decided principally, I never appear on behalf of patient. I always appear on behalf of doctors only. So we should be very clear as far as our colleagues are concerned, and we should never appear against our colleague. Let us see last case and we will conclude. Woman underwent diagnostic hysterolaparoscopy, post-operative blood accumulation in abdomen, and it was suspected vascular injury. Had to undergo second surgery, died due to excessive blood loss. In this particular case, defense in such a case, so many a time, few of our friends have a habit to send sample of blood in nearby blood bank and to keep at least 2 units of blood or PCV ready. If at all it is required, then only they will demand. And if it is not required, it's fine. It shows your abundant caution and it becomes good defense in court of law whenever you are facing this type of problem. What is liability of person call for help in emergency? So many a times one of our colleague is in trouble and we have to attend him. So in this type of situation, is that second person who is going for help is liable for any problem. Of course, patient may make party, but court is very liberal. So what is good Samaritan law? I said there is no Samaritan law in India, but court always consider our approach that whenever second person joins to save life of patient or to tackle the situation accordingly, then he is always pardoned if he has not done big palpable blunder. District Forum held doctor negligent in this particular case. State Commission held doctors not negligent, and patient died of reactionary hemorrhage and not due to vascular injury. It was inference held by the court and case was decided in favor of patient. So as far as pelvic hemorrhage is concerned, it could be obstetric, but today is not the topic for discussion. As far as gynec hemorrhage, pelvic hemorrhage is concerned, either it could be surgery or laparoscopy or conventional, and we have to deal with the situation accordingly. So which are the preventive steps? So in this type of situation, whenever we end up into litigation, first important question is asked, was it preventable? And usually we cannot say no. So one more question will come, what did you do to prevent it? And in spite of all our care and caution, we couldn't prevent. We couldn't prevent hemorrhage, or we couldn't prevent injury to bladder or ureter or so. So one very important question will come. Did you manage that complication way in which any prudent gynecologist would have managed? So if you can answer all those questions, then you could be out of problem. Should a common OBGYN closed bladder? Just I mentioned prior also. If urologist is available nearby, fine. Otherwise, you can very well repair urinary bladder, and you have to mention in your operative note how you have managed that closure of bladder injury. So medical legal implication of not calling urologist, we can convince court if urologist was not available and it was need of time to deal with situation accordingly. As far as problem with slings and meshes are concerned, so in this type of TOT, TVT, or which kind of mesh we should prefer, of course, we have to discuss with the patient with all its consequences, all its benefits and side effects. And because in many times just mentioned by Dr. Vinit Mishra also, mass erosion or infection related to mass or pain. So in this type of situation, it is likely that one may end up into litigation. But if we have explained everything fine, well in advance, then it could be good defense in our favor. So what to do, how to prevent? There is three things only we have to remember: foreseeability, anticipation, communication, proper consent, and documentation. So as far as anticipation or foreseeability is concerned, we have to explain all probable complications related to that very surgery or procedure which we are going to deal with. And we should be readily available to deal with those complications if at all it happens. Say, for example, if it is a case of vaginal hysterectomy with history of previous 3 LSCs, naturally we have to anticipate there could be addition and there could be injury to bladder. So we have to counsel patient accordingly in this type of situation, and we have to counsel that these are the possibility. If at all it happens, then we will deal accordingly. And if we have counsel patient that way, then it is very good defense in our favor. This is very important part, that is this judgment which came in one of the case, C. Jaipal Reddy versus Padmini Veluri. In that very case, National Commission has mentioned that consent is not mere piece of paper on which patient or patient party has to sign, but it is a very important document of your communication, of your counseling. So whatever you counsel, whatever you communicate, it should be entered into that consent paper. And once patient signs the document, it becomes a documentation of your communication. So whatever you have communicated to the patient, it is documented in consent paper. And once it is signed by patient, it becomes a good defense. But you have not to worry. You have to simply visit FOXI website. Under FOXI Uniform Consent, with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, MC Patel from Ahmedabad. We have prepared 30 different consent, and in all those 30 different consent, how to deal with hysterectomy, say for example, abdominal, vaginal, and endoscopic, or 3 different consent we have prepared. It is available in English, it is available in Marathi, it is available in Kannada, and Gujarati version is also ready. Hindi version is also on. So in near future, it will be available in those languages also. You have to simply download and use in your day-to-day practice. But whenever you explain anything to your patient, it should be in a very simple language. So avoid medical jargon. Would you give guarantee about result whenever you are dealing with case of SUI, TOT or TVT? So no rosy picture about, or no tall claim about result. Because in our surgery, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture. And records are always at our rescue. So we should have all the records in detail, whatever treatment we have done, which kind of surgery we have done, and it should be easily acceptable in court of law. So to conclude, this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many judgments available in our favor, but if you do not know, then they won't be useful. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way. So if you want to sleep like this, take tender care of your patient, comply with the provisions of law, pray Almighty God before going to sleep, and keep my visiting card below your pillow. So with regards, salute to all, and concluding with this humble appeal and request, please endorse my candidature for post of President FOXI election year 2026. Election would be from 1st August to 10 August, but before that, there will be nomination in month of April last week or first week of May. All the president and secretary are requested to nominate my candidature for this particular post. Thank you very much. Please do not assume, please ask if any query, any question, if chairpersons and time permit. Thank you very much.
So thank you, sir. Thank you very much. I'm so sorry to join late. I was stuck in traffic with no drivers, so I could not join in early phase. But from third or fourth slide, I joined. I must wish a success to our mentor, Dr. MC Patel sir, in this election. And I know you all are his supporters, including me, my society, Hingoli, Parvani, all. Okay. So we are with you, sir. So in advance, congratulations for you. You deserve that.
Yes, I would like to mention that, Ajay, I would like to mention that also. When I started this Happy Learning series, you were the first person whom I invited, and you were very happily joined this series. And you was with me at least for
2019.
2 years.
2019.
Yes, so at least 2 years you were with me in this particular series. So the same series still continued with same passion, and we are happy to continue this.
Yes, and today's talk was a marathon dose from Dr. MC Patel sir. So he has included everything. If we remember only 10% of today's lecture, we are into safe practice. That much knowledge he has given all of us. So thank you, sir. Thank you very much. And one more thing, he reminded us that if there is no complication, there is no surgeon. So almost all of us, 99.99%, we have faced the complications. These are bound to be there. And they are more with laparoscopy, hysteroscopy, because the actually end of these instruments, they are not in our hand or control. They may go 1 or 2 centimeters because the vision is 2D. Nowadays, it is 3D coming with that and robotic surgery, but I have not seen robotic surgery performing. So, as sir said, injuries are more in instrumental. Okay. So, be careful and don't skip the SOP or the protocols. That is the crux of today's sir's lecture. Okay. Sir, thank you very much.
Yes, thank you. Stick to protocol. Yes, Monica.
Yeah, thank you, Ajay sir. And once again, thank you to MC sir. It's always a delight to hear MC sir. Over and over again, we can hear, but it's always a delight. Ajay sir, thank you so much. Yes, we will now move on to the panel discussion.
Thank you, Shatabdi.
We have a panel discussion on complications of hysterectomy. We have Dr. Tasneem Fasiha ma'am and Dr. Dinesh Devidas sir as our moderators. Our expert panelists are Dr. Srinivas Gadappa and Dr. Lakshmi ma'am. Over to the CVs, please. Dr. Fasiha Tasneem ma'am is an associate professor and unit head at the Department of OBGY at Dr. SC GMC Nanded. She has over 21 years of experience in high-risk obstetrics and is an expert laparoscopic surgeon and infertility specialist. Welcome, ma'am. And we have Dr. Dinesh Devidas sir as our other moderator. Sir is a consultant infertility specialist and endoscopic surgeon at Ankur Super Speciality Hospital at Nanded. Also an ex-assistant professor at BJMC Pune with an experience of over 19 years. Welcome, sir. Our experts for the session are Dr. Srinivas Gadappa, sir. Sir is the professor and HOD at the Department of OBGY at Government Medical College, Chhatrapati Sambhaji Nagar. He has pioneered the Respectful Maternity Care Initiative in partnership with the White Ribbon Alliance. Welcome, Srinivas, sir. Our next expert panelist is Dr. Lakshmi Rachakonda, ma'am. Ma'am is a professor and HOD at MGM Medical College, Aurangabad, Maharashtra. She has been the past president of Aurangabad OBGY Society and past treasurer of Amox Yuva Foxy, End World and 12. Welcome, ma'am. We have 10 panelists with us. Our first panelist is Dr. Dilip Nagargoje, sir. Sir is a senior gynecologist at Godavari Hospital, Gangakhet district at Parbhani. Over 20 years of experience and with special interest in fetal medicine. Welcome, sir. Next is Dr. Ananya Mahale, ma'am. Dr. Ananya is a consultant at Mahale Hospital at Nanded from 2023 onwards. Welcome, Dr. Ananya. Next is Dr. Aparna Raul, ma'am. Dr. Aparna has been the secretary of the Aurangabad OBGY Society as well as the president of the Aurangabad Society between 2023 and 2024. She runs the Noble Nursing Home and International IVF Center. Welcome, Aparna, ma'am. Next is Dr. Leela Karpe. Dr. Leela is a consultant at Karpe Hospital since 23 years and an assistant professor at GMC Hingoli. Next is Dr. Pranita, ma'am. Dr. Pranita, ma'am, is a consultant at Zadpe Hospital at Hingoli, practicing since the past 8 years. Welcome, ma'am. Next is Dr. Sapna Partani, ma'am. So Dr. Sapna is the current secretary of the Parbhani OBGY Society, working as a gynecologist since the past 10 years. Welcome, ma'am. Next is Dr. Narendra Verma. Dr. Narendra Verma is a practicing OBGY at Parbhani since the past 23 years. He has worked as medical superintendent as well as lecturer at GMC Nanded. Welcome, sir. Next is Dr. Pranjal Joshi, ma'am. Ma'am is a practicing gynecologist at Chintamani Hospital, Nanded, has been the secretary and past treasurer of the Nanded OBGY Society. Welcome, ma'am. Next is Dr. Nagappa Niture, sir. Sir is a consultant gynecologist and director at Sri Yogeshwari Hospital at Nanded. Also has been the organizing secretary of AMOX 2017 Nanded. Welcome, sir. Last but not the least, we have Deepak Panditrao, sir. Sir is a consultant at Vatsalya Maternity Home at Parbhani and at Vignahartha Multi-Speciality Hospital, Parbhani, and specializes in high-risk pregnancy. Welcome. Over to you, ma'am and sir, for looking forward to a good panel discussion.
Thank you so much, ma'am, and very good evening to respected MC Patel, sir, our program director, and all the coordinators of this Core Connect program. Respected Kanan Yedikar madam, respected Pardeshi sir, and our guest of honor Atnurkar sir and Pandit Palaskar sir. I also welcome our expert, respected Professor Dr. Srinivas Gadappa sir, Professor Dr. Lakshmi Rajkonda ma'am, and all our panelists. This is going to be a panel discussion on complications of hysterectomy, whichever is the route. We are going to discuss the complication to the procedure specific complications. And I think not all the panelists have joined. I could see only 6 panelists who have joined. I don't know if other panelists have joined with the other names. I could see Dr. Niture sir, Dr. Deepak Gatti, Dr. Ananya Mahale, Dr. Dilip Nagargoje sir, Dr. Leela Karpe ma'am, and Dr. Anil Rathod. So,
hello and a very warm welcome. We would like to share our screen. Please allow us. Can you see the screen? Are we audible?
Yes, you are audible.
Okay.
The screen is not yet shared. You have to start sharing. And now it is visible, ma'am. Please make it full screen.
Okay. Let's see. So as we all know, hysterectomy is the most common procedure carried out in OB/GYN worldwide. It is the simple surgery and much simpler, I must say, when it is unnecessary. Each operation has its own complications, so is with hysterectomy. Complication chances are more when the hysterectomy is actually indicated and it is done in patients with high risk factors like obesity, previous surgeries, medical disorders like diabetes, hypertension, etc. Complications are unique to the procedure itself and also to the route of the hysterectomy. The principle of management is anticipation, good counseling, prevention, early detection of complications, and prompt management. And this is the best way to deal with the complications. Over to you, Dr. Dinesh.
This is the first case scenario. It's a 45-year-old lady, para-2 living to with previous normal deliveries, presented to OPD with a heavy menstrual bleeding. On examination, the uterus was 14 to 16 weeks. It was firm, irregular mass felt per abdomen. Ultrasound showed that it was a multiple fibroid uterus, and hysterectomy, abdominal hysterectomy was decided. After hysterectomy was done, post-operatively, it was noticed that patient was in hypovolemic shock after 6 hours. Pulse was 110 per minute. Blood pressure was 80/60. There was pallor. Abdomen was distended and tender. What surgeon should suspect in this condition? May I ask Niture sir, what will be the clinical diagnosis and further plan of action in such type of presentation?
Dr. Niture sir, can you hear me? Hello?
Okay, I think sir is not audible. Can Dr. Deepak Gatti take this question?
Yes, sir. As the patient had undergone the total abdominal hysterectomy and the uterus was big and there is a mass of size 3/2 and 5/3 3.5 centimeter approximately. And the signs and symptoms as per the case scenario, patient is in hypovolemic shock and pulse rate is 110 per minute and blood pressure is 80/60 and patient is pale, abdomen is distended and tender. These signs and symptoms indicate that there must be connection in peritoneal cavity, which might be due to slippage of ligature or pedicle, or hemorrhage from the veins, which might be get collected during the 6 hours. In such scenario, we have to resuscitate the patient hemodynamically prior and make arrangement for blood.
Yes.
You can do bedside ultrasonography to diagnose the collection or to confirm the collection inside the peritoneal cavity. And if you have the facility of laparoscopy, you can put a scope inside the peritoneal cavity and you can see the scenario.
Yes. Yes. So it is clinically evident that she is bleeding inside, maybe from a slipped pedicle. So
yes.
So what are the risk factors for excessive intraoperative bleeding? May I ask Dr. Ananya Mahale? What are the risk factors for excessive intraoperative bleeding?
Yes, sir. So the risk factors for in this case for intraoperative bleeding, because it was a fibroid uterus, that too a large uterus, it is very likely that the ligature slippage and bleeding from the pedicles is very likely in this case. Also,
Not particularly in this case, for any hysterectomy, say what are the risk factors? In what type of cases, in what type of hysterectomies you expect excessive bleeding? What are the situations? So, if the patient is obese, if there are large uteri.
Can I speak, sir?
Yes.
I think one thing, not only in this patient but anything, is actually what is the uterine pathology for which we are going the hysterectomy.
Yes.
Like it's a
Yes.
fibroid, as she has already told, and whether it's a pelvic inflammatory disease where the congestion is more, or endometriosis. Other is obesity of the patient, the pre-existing anemia. These are all high risk factors where you could anticipate that this patient could be at a very high risk of bleeding. So this can be taken fair, and inadequate hemostasis, mainly when the blood pressure is a little low while we are
Yes.
closing the abdomen, and then suddenly it shoots up and the bleeder then comes out. So these are
Yes.
the
So reactionary hemorrhage can happen. So obesity, large uteri, in presence of chronic infection, say large vessels, okay, large myomas, myomas on abnormal locations, history of, operating in a patient with the previous surgeries, excessive use of cautery for hemostasis later on can cause sloughing and bleeding. Okay, so these are the risk factors for excessive bleeding. Okay, so the next question is, what is a reactionary hemorrhage? What are the causes and its management? May I ask Dr. Dilip Nagargoje, sir? Dr. Dilip Nagargoje, sir? Okay. Next person can Dr. Leela Karpe, madam?
યસ મારો છે ને વેબિનાર એક ચાલે છે, એટલે મારું લેક્ચર પતી ગયું છે, અત્યારે પેનલ ચાલે છે, પણ છેલ્લે પેનલ પૂરી થાય એટલે ખાલી એક થેન્ક્સ કહેવું પડે મારે, કારણ કે સિરીઝ આપણી પોતાની છે એટલે.
Hello. Any panelist who is available can take this question. Reactionary hemorrhage and what are the causes?
Patel sir, please mute yourself.
See, actually, reactionary hemorrhage is the hemorrhage which occurs in 24 hours of the surgery. For example, loose ligature, when you're closing the abdomen while the patient is in hypotension, and evidence, and then later on blood pressure is shooting. So if for reactionary hemorrhages, when there is a lot of bleeding inside and patient is hemodynamically unstable, pre-operation is necessary to achieve the complete hemostasis, either by laparoscopy or laparotomy, whichever the facility you have and whichever the procedure you are master in. The next question is, what is the secondary hemorrhage? What are the causes and its a management?
Anything which occurs after 24 hours.
Yes.
But maybe up to 14 days. Main cause is infection, sir.
Yes.
Maybe that is the one where the slough is there, or slipping again of a ligature, but mainly due to infection is the commonest cause of
Yes.
this. Very
Yes. And the treatment will be?
Antibiotics. Then some, very rarely you could have to go for a relook laparoscopy or
Operative
laparotomy.
procedures.
Yes, operative procedure.
And sometimes it happens that even if you give antibiotics, even if you do surgery and try and achieve the
It's not-
hemostasis, you may not get actually the bleeder completely in your hold. For example, sometimes the descending vaginal artery bleeds vaginally, and it is not accessible for the routine hemostasis. So sometimes interventional radiology help can be taken to block the bleeding vessel. Yes.
Coming to the second case. So here we have a 50 years old para 2 previous to cesarean section who came with heavy menstrual bleeding PV, the diagnosis as adenomyosis, and the plan was to take her for abdominal hysterectomy. She was taken for abdominal hysterectomy, and intraoperatively, while separating the urinary bladder, surgeon noticed that the Foley's catheter bulb is seen in the feed. So what's your diagnosis? Dr. Deepak, would you like to take this question?
Yes, ma'am. As the history suggests, she is a case of previous to LSAS, and she had operated for. She was planned for total abdominal hysterectomy. Due to previous to LSAS, there may be the chances of adhesions, and during separating the adhesions, means adhesolysis, the patient, the surgeon might have opened the urinary bladder, and the Foley's bulb is visible.
Okay.
It's more common during previous surgery, previous LSAS or previous 3 LSAs.
Yes. And she's a case
As
of
the
previous
bladder
to
is
cesarean
late
section.
advanced, and there is dense adhesion between lower uterine segment and urinary bladder. The chances of opening the bladder or bladderette is more common.
Okay. So how to prevent bladder injuries in these patients while doing adhesolysis and separation of bladder from anterior wall of the cervix?
Uh, uh, as you see, the bladder is added to the lower uterine segment. As much as possible, you can do the sharp dissection, and you can go laterally to medially, where the most of the times bladder is added more centrally. You can go from lateral to medial, dissecting doing sharp dissection.
Okay. So we have to anticipate in such cases where who are especially previously operated or cases of previous cesarean section, that the bladder dissection is really going to be difficult. So here we can take help of lateral window technique, which is the best approach for bladder dissection in such cases. And one more thing we have to keep in mind is that we have to keep the dissection field bloodless so that the tissue planes are properly visible.
Yes, sir.
Next question is for Dr. Ananya. How to detect bladder injuries during surgery?
Bladder injuries during surgery, especially in cases of hysterectomy, the injuries occur while we are dissecting the UV fold. So it is the cystotomy which happens is generally very obvious and not missed. However, it can be seen by the appearance of Foley's catheter or the urine leaks out. So
Okay.
this is the way to detect, and also we can do a dye test, and if there is leakage of dye, that also indicates injury of bladder.
Injury of bladder, exactly. So visible bladder mucosa or Foley's bulb. In cases of laparoscopic hysterectomy, we will find one more thing, that urobag will be full of gas. In cases of small injuries that may go unnoticed, but they can be detected by retrograde filling of urinary bladder with a diluted methylene blue saline which can detect those minute injuries which would have gone unnoticed. Okay, so my next question is to Dr. Karpe madam. How to manage intraoperatively such bladder injuries?
Such bladder injuries can be directly managed intraoperatively by taking sutures in 2 to 3 layers with 2,0 Vicryl.
Yes, excellent. Okay.
And we have to keep the catheter for 7 to 10 days, up to 21 days can be, if
Yes.
there is major injury.
Yes, previously bladder training used to be mandatory before removal of such Foley's catheter, which are done after bladder injury repair. But nowadays it is said that the guidelines are that that bladder training kind of thing is not necessary before removal of catheter.
Madam,
so
can I
traditionally-
add one thing?
Sure, ma'am.
Just because we are in an institute, you also know that whenever we have the question was the Foley's is suddenly seen. So now very over enthusiastic junior faculties and resident, they try to intervene there only, like see really is it, so that will increase the, so that they have to be careful. Once they find, I think they should stop and call an expert or a senior person. This happens when we are practically working in an institute, I think.
Of course. So we must take the help of urologist.
Yes.
Yes.
And the thing that initially, previously we used to keep the catheter for 3 weeks. Nowadays, they are not keeping that long, 7 to 14 days max they are keeping. And after we finish the prolonged catheterization, when we are removing the catheter, bladder training is not required. Actually, we can take the catheter out right away.
Yes. So my next question is to Dr. Deepak again. How to suspect bladder injuries in the post-operative period?
Patient might have leakage post-operatively, or patient may have voiding difficulties.
Okay.
Or post-operatively patient may have hematuria, or if
So
the bladder,
we are talking about the injuries which are detected in the post-operative period, isn't it? A little bit late. So
May I talk?
Post-operative days or weeks. Yes. Yes, please.
Patient post-operatively, if in bladder injury, we can detect by distension of abdomen. Patient may have fever. Patient may have fever with chills and rigor.
Yes.
He might present with less urine output.
Yes. Yes. So the urine output will be decreased. There can be hematuria, there can be abdominal distension, even blood urine and nitrogen will be elevated in the laboratory investigations. Also, in cases of suspected VVF, so it will be detected again late. So the vaginal secretions are tested for creatinine levels and they are compared with serum creatinine level of the patient. And if the secretions creatinine level is more than the serum creatinine of the patient, that confirms vesicovaginal fistula. Okay. Anybody would like to add anything in this? My next question is to Dr. Anil Rathod. How to manage such injuries detected post-operatively? Anil, are you there? Hello?
Anyone can
Fine.
take this
Anybody
question.
can take it. Deepak, would you like to take it?
yes, ma'am. If the patient has having distended, hello.
Hello. Yes.
If the patient is having distended bladder, we have to recatheterize the patient. And if the patient is having leakage, means diagnosed vesicovaginal fistula, we have to repair the fistula. And
start her on antibiotics. I think we can start her on antibiotics. As sir said, recatheterize, call a urologist, do a test, cystography, and then accordingly, I think in coordination with urologist, we should go ahead with this.
Yes. So the management
if you are suspecting the injury immediately post-operatively, you have to reopen the patient and find out the rent or injury to the bladder and repair accordingly.
So it depends on the timing when it is detected, isn't it? So if it is detected early, we can go for immediate reoperation because these are the clean injuries, right? But if once it is detected late, maybe after a week or so, then there will be a
There
lot
is
of
lot
edema and
of edema,
inflammation. So
yes.
we want, yes, we want that edema and inflammation to subside. Then only we can go for the repair. So the right period is after 3 months to repair it. Fine. We would like to ask our expert if she would like to give an expert comment on this, in this case entirely.
No, I think I would agree with whatever everybody said. Only thing is involving, because we are institute always involving, so that we medico-legally are also very much safer. That is
Yes.
in
Yes.
documentation, because and explaining to the communication, because injuries can occur. It's not like only explaining, detecting them at the earliest and treating is documentation. That is very much important.
True.
Yes, ma'am.
True.
Yes, thank you.
Over to you, Dr. Vinod.
So third case scenario, 45-year-old lady, para 3 living previous 3 normal deliveries, complaining of pain in abdomen since 2 months, feeling of incomplete voiding and difficulty in passing the urine. On examination, there was evidence of a large round mass felt during bimanual examination. It was firm in consistency and mobile. Ultrasound confirmed that there was a posterior wall cervical fibroid around 10 by 10 centimeter size, pushing the bladder anteriorly, and patient was taken for abdominoplasty. While taking the uterine pedicle, surgeon suddenly noticed that ureter is cut. What next?
So calling the urologist immediately.
Yes.
I think that should be the,
Immediately.
and
Yes,
I would
because
say,
now-
ki when you're having this case, I think coordination with the urologist beforehand, that you are going to go for a cervical fibroid, because these are areas where the likelihood of injuring the ureters is very much. So beforehand,
Yes, ma'am. Here the anticipation is very
anticipation
important.
is important. Yes.
Because you know that you are dealing with a case of cervical fibroid, you should be well versed, with doing such type of cases in a place where the additional, expertise of urologists are available. It should not be done by a person who is not very competent in a place where urologist is not available. So this is also important, pre-operative planning.
Yes, sir.
So what are the
Sir,
situations? Yes.
sir, if there is no urologist or a surgeon available in very periphery area, then
Yes.
one can put the infant feeding tube 7 or 8 number in ureter and take it out from abdomen, close the abdomen, and can refer to higher center if there is no availability of a surgeon
Yes,
also.
here you are, ensuring that the urine is not leaking inside the peritoneal cavity. Whatever is leaking should come outside, so that there should not be infection inside, right? That's a good
Yes.
approach. That's a
Yes.
good approach, and then you can refer the patient immediately for further treatment.
Yes.
So, my next question is, what are the situations during hysterectomy where there are more chances of ureteric injuries? Nagargoje sir. Dr. Dilip Nagargoje sir. Dr. Ananya Mahali, can you take this question?
Yes, sir. So the situations can be in the presence of distorted anatomy, especially like large
Correct.
uterus with multiple fibroids or large cervical fibroid, broad
Yes.
ligament hematoma,
Correct.
and also
Broad
in the
ligament
presence
fibroid.
of endometriosis and chronic pelvic inflammatory disease, and
Previous
also
surgery.
previous adhesions because of multiple surgeries like previous LSCS or any pelvic surgeries.
Yes, basically the myomas at abnormal locations distorting the ureteric anatomy, ureteric course, endometriosis, chronic PID. These are the cases where you get a lot of adhesions and they disturb the normal anatomy and the normal course of ureter. So here
even
are the
even in
conditions.
malignancies when we are
Yes, ma'am,
Yes,
definitely.
malignancies.
Yes. So, in such type of cases, injuries are common. So, how to prevent ureteric injuries in such patients? So what are the strategies? Now you know that this patient is, liable to get ureteric injury. high risk for ureteric injuries. So what precautions you will take? Dr. Deepak Gatti, sir?
Yes, sir. You should be well versed with the anatomy of the ureter.
Yes, normal course anatomy, right?
Yes, and in case of if there is a adhesions multiple due to multiple surgeries, you should tissue identification in such case is very much important. You should do adhesiolisis sharply, sharp dissection, and
Yes.
as much as possible, you should go.
In a routine hysterectomy also, if the technique is clumsy and not proper, ureter can be damaged. So for all
Go
these
close.
therapies, whenever you are clamping the uterine artery, it should be close to the
Close.
uterus medially and never laterally. Adequate bladder dissection should be there with a dissection of posterior peritoneum and good upward traction to the uterus so that ureter falls laterally. So this is the basic technique to be applied for all the hysterectomies.
Sir, and when
Right.
we are doing for difficult surgeries like
Yes.
like a broad ligament, and then you can go
Yes.
for a
So in
pre-operative
cases,
stenting also,
right, ma'am.
where the
Exactly.
anatomy is distorted.
Yes. But they also say there's also one school of thought that if you are catheterizing the ureters, it is easy to identify, but it will not prevent injury. So in cases
okay.
where the anatomy is distorted, we should be well versed with opening the retroperitoneum, dissect the ureter throughout the course, and keep the ureter under vision all the time. So this is the best practice to prevent ureteric injuries, especially in case of endometriosis and also the large cervical fibroids.
Sir, I would like to mention here about the role of intrafacial hysterectomies.
Okay.
If it is not for a malignant cause,
Yes.
then
Yes, especially not stage 1 endometrial malignancy. Yes. Please go ahead. I think we lost her voice. Can Dr. Anil Rathod throw some
Yes,
light on this?
Pardon, sir?
How to manage these ureteric injuries during hysterectomy? How to manage? Now injury has occurred. Intraoperatively, you have detected.
Yes, sir. If injury is just crushing of a ureter by clamp, then we can complete the case. We have to call urologist and do cystoscopy and do ureteric stenting. And if injury is sharp injury and ureter has, then we have to do ureteric reimplantation.
Yes.
If
So
there is
yes.
electrosurgical injury, thermal injury, then also we have to put the ureteric stenting.
Yes, actually, thermal injuries, you may not detect every time intraoperatively. If it is a very obvious that directly you are cauterizing on the ureter, in that case only you can suspect injury. But if you cannot suspect the lateral damage, okay.
Yes.
So intraoperatively to detect the cautery injury is little difficult. It present usually late, a week later of the surgery. But mechanical injuries, crushing injuries, transactional injuries can be detected intraoperatively. In that case, no, usually it happens that now, just now in the previous MC Patel sir's lecture, we saw that 80% of the injuries are in the lower ureter. So it is easy for us to do ureteric reimplantation. And it is done by keeping the digest stent in situ. And after 6 weeks of surgery, we can remove that stent. All right?
Yes, sir. Thank you.
So, is Nituri sir there? No. Okay. So my next question is to Dr. Karpe, madam. How does this ureteric injury present during post-operative, late post-operative period, and how to manage such ureteric injuries which are detected post-operatively?
In the late post-operative period, patient may have fever. She
Yes.
may have voiding difficulties. She may have distension.
Yes.
And
Excellent.
yes.
Yes.
So there
And
could be
clinically,
flank pain is also there. There is many
flank pain,
times
fever,
flank pain.
vomiting, distension, bowel obstruction, and they may present as a urinary, ureterovaginal fistula also. So, CT,
So
IVP
it
is,
again depends on, sir, when it is manifesting, 1 week, 2 weeks,
yes,
3 weeks.
yes, madam. If it is early presentation, more of it is a fever, abdominal pain, and
Yes.
distension. If it is a late presentation, mostly they will present as a vaginal.
Hydronephrosis.
So CT, IVP is done. And the good thing about ureteric injury is that we don't have to wait for 3 months like we have to wait in a bladder injury cases, delayed detected bladder injury cases. So once detected, it can be immediately repaired, except if the patient is having a lot of fever, pain, and edema. In that cases, you can give antibiotic, reduce the inflammation, and then plan maybe after 1 or 2 weeks after the infection control. So ureteric reimplantation post-operatively should be done whenever you detect the ureteric injury. And when the injuries are late, they present as a ureteric fistula. So can Nagargoje sir may talk about the ureteric fistula management? Dr. Dilip Nagargoje sir? Dr. Deepak sir?
Yes, sir. Uh, Depending upon the size of the fistula, you can manage the fistula. If it is small, then we can give conservative management, catheterization, and antibiotic. If it is large, then uh, uh, we can do depending upon the site of extent of ureteric, we have to do either ureteric reimplantation surgery or
Yes.
mobilization surgery.
Yes.
And
If the
if
stenting is possible, only stenting can take care. If the stenting is not possible, we have to do ureteric reimplantation.
And if I would say if the renal function by chance is compromised, then maybe we have to do you can say nephrostomy first and then go for the repairs.
Yes, if there is hydronephrosis, renal function is hampered, and patient is not fit for immediate surgery, then you may do diversion of the urine. And when patient recovers, when the morbidity decreases, you can go for definitive procedure.
Coming to the fourth case scenario. So here we have a 48 years old woman who has dysmenorrhea, chronic pelvic pain, and dyspareunia, and her ultrasound was showing endometriomas and uterus was adherent to rectum and sigmoid colon. She was posted and laparoscopic hysterectomy was done. There was densely adherent sigmoid colon which was separated with blunt and sharp dissection. Postoperatively, patient developed fever, abdominal distension, vomitings, and absent bowel sounds on day 3. So I would like to ask to Dr. Deepak, what is the diagnosis in this case and how we should manage?
Intraop, there was dense adhesions between sigmoid and the uterus, and patient had fever after 3 days with abdominal distension and vomiting. These signs and symptoms indicate that the patient may had bowel injury, that is mostly sigmoid.
Okay. So how can we prevent? How can we prevent
Madam,
such
there
bowel
could
injury?
be, it's a laparoscopic, right, madam? It's a laparoscopic.
Yes,
There could be a
laparoscopic.
thermal injury.
Yes.
I think somebody is not on mute, I believe. That's right.
And I think two, I mean, the person may be having two links open at the same time.
Okay. So how can we prevent such bowel injuries in such cases who are high risk for getting these bowel injuries? What is the pre-operative preparation, in other words, I must say, for such patients? Deepak, can you take it? Dr. Anil?
Yes, madam. We have to suspect deep infiltrating endometriosis, and we should do MRI by dedicated endometriosis center.
Okay.
And with, diagnosis of deep endometriosis. So we have to keep this patient for operation.
Yes. So to prevent bowel injury in such patients, what pre-operative preparation you want to do after doing this
good
confirmation
bowel
of investigation?
Good bowel
bowel preparation.
Excellent. Yes. Yes, bowel preparation.
So
So what you would like to prefer? What you would like to prefer for that purpose? Anybody can take this. Fine. So for me, personally, I would like to prefer Pegleg enema and a liquid diet 24 hours prior to surgery. That will give us an excellent bowel preparation, and the bowel will be collapsed, and there will be less chances of bowel injury while we are dissecting. So our next question is that, of course, how to prevent bowel injuries. So first is this bowel preparation, and then anticipation of which Anil has already rightly said, okay, what grade of endometriosis it is, and then good bowel preparation and good dissection and involvement of general surgeon whenever we encounter such kind of injuries is a must in such cases. So my next question is to Dr. Deepak, how to manage bowel injuries intraoperatively, if at all it happens intraoperatively. How will you proceed?
If whenever you detected the bowel injury, you can call a surgeon for the help. Then you can suture the bowel with absorbable suture in 2 layers. And if the bowel injury is more, or extent of the injury is more, you have to do section and anastomosis.
So again, it depends on the size of the defect. If it is small, then primary closure is done. And if it is a large one, then dissection and anterior anastomosis should be done. And if bowel injury occurs in an unprepared bowel, then stoma must be created, and stoma closure is done after a period of 6 weeks. Okay, so identified by Truecaller. This is my question to the expert. Is involvement of general surgeon is mandatory, madam?
It's not mandatory, but I think for you mean for repair you are asking?
Yes.
Yes, I think so. Yes, I think so. Because they'll be in a better position. Maybe unnecessary, there'll be a leak if we repair it. We are not used to that.
Yes, and again, medical legally also will be safe.
Yes,
and
we
as
are safer.
Patients' improvement and healing, there will be an excellent recovery because they are. It is, I must say, bowel is their field, so it's good to have a general surgeon.
Practically, bladder is little easy for suturing, but bowel is little.
Bowel is little difficult.
Bowel is a little complex.
We as the gynecologists are not very comfortable in dealing with bowel.
Yes. And now we are more safer. Medical legally, we have to think.
Of course.
Yes, that is.
Okay, so what if these bowel injuries do present post-operatively, and how one should manage it? So this question of mine is directed to Dr. Leela Karpe, madam. Madam, would you like to take it?
Yes, ma'am. Yes,
Please.
yes.
Yes.
We have to keep the patient NBM.
Very good.
We have to do the ultrasound. SOS can be done, CT scan to see
Yes.
any collections. and we have to done the routine blood investigation, sodium, potassium,
Yes.
and general surgeon involvement.
Yes. So we need a second surgery, of course, for creation of a stoma, and then after 6 weeks we will post her for a definitive repair or definitive surgery. Okay, madam, my second question is also to you only. How would you like to manage such case if she develops post-operative ileus or subacute intestinal obstruction? Dr.
If
Leela,
there
ma'am.
is yes, if there is a post-operative ileus, then we can keep the patient NBM for 24 hours and see the sodium potassium levels and IV fluids, and then after coming up the bowel sound, we can shift her on to the liquid diet and then semi-solid diet.
I would like to add the electrolyte imbalance is to be seen over here.
Yes.
Mainly,
yes.
and the decompression by putting an RT.
Yes.
Riles tube.
Nasogastric tube. Nasogastric tube or Riles tube, we must say. And of course, correction of electrolyte imbalance. Okay. Fine. So over to you, Dr. Dinesh.
So we are moving towards case scenario 5. 54-year-old lady, postmenopausal, known case of diabetes, hypertension. She was obese, BMI was more than 30, and she was posted for abdominal hysterectomy with bilateral salpingo-oophorectomy for cystic hyperplasia with atypia. And on post-operative date time, she came with a high-grade fever, which was severe severe lower abdominal pain with a decreased bowel sounds and abdominal distension. On pelvic examination, there was a tender and swollen vaginal cuff with little purulent discharge coming out through suture line. Lab findings showed that there was a leukocytosis, CRP was elevated, and also mild AKI. So, what is the diagnosis and what is the approach? Dr. Ananya Mahale.
Yes, sir. Yeah.
Yeah.
So the diagnosis is here, it is peritonitis, sir. It is mostly pelvic abscess from
Yes.
infected vaginal vault, most likely.
Yes. Because she was diabetic also, more prone for infections.
With the background of diabetes.
Yes. So, Dr. Ananya, can you tell me the clinical presentation of post-operative sepsis after abdominal hysterectomy? How they present?
So the patient, the general condition is not good. They present with fever and foul-smelling vaginal discharge.
Yes.
Also, there is pain which is more than that is expected of post-operative pain.
Yes, patient is not comfortable, right?
So, and her general condition is not.
Yes, she will have pus leaking either from the vault or from the incision, persistent nausea, vomiting. So, what are the management options?
Management option includes first is proper diagnosis with the help of imaging modalities and blood investigations.
Yes.
And then broad spectrum IV antibiotics.
Correct.
And there should be a very low threshold for repeat laparotomy.
Operation. Correct.
Yes.
Usually, smaller abscesses can be managed conservatively if the patient is stable. But if the patient is unstable, hemodynamically not good in sepsis, or the abscess is more than 8 centimeter, you need to drain them.
And stepping up immediately, recognizing it early, stepping up and shifting to ICU is important because she could land up into
septic shock. Yes. So that thing should be we should keep in mind, and that also counseling should be done to the relatives that we are treating. That's it. But if she worsens, the ICU option should be available, and if it is available, it should be done in ICU with priority. So if the abscess is in pelvis, if it is accessible through vault switches can be opened up and drained vaginally. And if it is not accessible vaginally, if it is up in the abdomen or in the adnexa or in the parametra, you need to do laparoscopy or laparotomy. So there are different types of post-operative infections like vaginal cup cellulitis, pelvic cellulitis, pelvic abscess, and incisional abscesses. Cellulitic stage we can manage with IV or oral antibiotics, and if she responds, then no further treatment is required. For pelvic abscess, just now we discussed that it needs to be drained under the broad spectrum antibiotic. And incisional infections like superficial or deep surgical site infections, sutures or staples should be opened, the pus should be drained, wound care should be done with sterile dressings, should be given broad spectrum antibiotics, and that should solve the problem. So surgical interventions and all we have discussed, drainage, wound care. Okay, and if the patient is in septic shock, if the abscess is ruptured into the peritoneal cavity, it is an emergency situation. She should be shifted to ICU and should be intervened on emergency basis. Antibiotic regime, we just now discussed that it should be if the pelvic cellulitis is there or abscess is there, it should be a combination of antibiotics which will cover aerobic and anaerobic cocci and bacilli. So our routine combination of penicillin or cephalosporin derivatives along with gentamicin with metronidazole will be sufficient. If it is not responding, you can step up towards piperacillin tazobactam combination or carbapenems. And once the patient responds, okay, you can switch over to oral antibiotics. Dr. Anil Rathod, can you tell us the key risk factors or etiologies of this sepsis after the abdominal hysterectomy?
Yes, sir. Risk factors are known case of diabetes mellitus, obesity, prolonged surgery.
Yes.
Yes.
Anemia.
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 So if they have nowadays, we are coming across so many liver diseases the patient has, or the kidney diseases.
Yes, any
So
morbid,
any comorbid
morbid
condition.
patients will have a decreased immune response.
Yes.
You'll need to unlock your iPhone first.
Yes. And if I know this is a very common and very normal thing that we should be excluding bacterial vaginosis before taking these patients for abdominal hysterectomy. If it is there, you should treat it. And it is a good policy to use betadine pessaries a night before your planned abdominal hysterectomy. So these are the strategies for a prevention of infection, correction of morbidities like anemia, diabetes, hypertension, or any other chronic morbidities, improve the nutritional status, optimize the morbidities, treat the bacterial vaginosis or local infection, and use pessaries a night before, betadine pessaries a night prior to surgery.
Coming to the sixth case scenario, here we have a 50 years old post-hysterectomy patient who presents to us on day 5 with complaint of pain in left leg and swelling. So, Dr. Ananya, would you like to put some light? What is the diagnosis in this case?
She's post-hysterectomy day 5 and presenting with pain in left leg and swelling. I'll have a
Yes.
very high suspicion for deep vein thrombosis.
Okay. Very
And
good.
even before investigating, I would like to start her on anticoagulation and then go for investigations.
Okay. What investigations would you like to do?
Ma'am, as simple as a Doppler study,
Okay.
ultrasonographic Doppler study,
Mm-hmm.
and then we can go for CTPA,
Okay.
duplex scan,
Mm-hmm.
and lab findings also can be elevated, like fibrinogen levels and D-dimer levels.
Yes.
Yes.
How will you manage this case?
Management option
Dr.
is
Anil, would you like to answer this question?
Yes, ma'am. First of all, I will like to say the prevention of DVT. So
Mm-hmm.
DVT can be prevented by giving adequate IV fluids and oral fluids whenever patient is uh, has started the oral. Then we have to give plenty of oral fluids to patient, and we have to ask patient to ambulate as early as possible.
Yes, early mobilization is very important.
Very important. And if a patient is obese or BMI is very high, more than 30, then we have to start low molecular weight heparin.
Yes, yes,
It
exactly.
start- Yes, ma'am.
Even
And
if
if
patients undergoing
we
prolonged
have
surgeries, sorry, you can continue.
physician and start low molecular weight heparin.
Okay. In the dose of
And
1
it should
milligram per kg twice a day, isn't it?
4 to 6 weeks. Yeah.
And
Okay.
I think even in high-risk surgeries, leaving whatever is told about obesity, even patient taking prolonged surgeries, like we do a radical hysterectomy also, all those
Yes,
having
yes,
an extended
yes.
trip, it is always good prophylactic.
Yes, we are
And
coming to
we
that
are
point.
just giving, okay.
Yes. So what are the cases where you would like to have DVT prophylaxis? So this is the list, I must say, that obesity age more than 60, then prolonged surgery, whose duration is more than 90 minutes or so. Special cases of malignancy, they are also more prone for DVT. So among the preventive measures, I must recommend intraoperative and postoperative use of mechanical compression devices. And as everybody has rightly said, that low molecular weight heparin can be started 12 to 24 hours post-op if there is no active bleeding present, in order to provide the best prophylaxis for DVT.
Madam, how many days do you continue in your institute for this prophylaxis?
It is recommended that it should be continued for a month, ma'am. For a month, 30 days.
No, in this prophylactic, whatever surgeries we have discussed. Not as a prophylaxis.
Yes, yes. If the conditions, only as a prophylaxis, the patient, it can be given for a week till the patient becomes ambulatory.
More ambulatory. So we should not cut short for 3 days. It is better
Yes.
to prolong it.
Yes. For a week, up to 10 days can be given till the patient becomes, little comfortable with the surgical pain and is ambulatory.
Yes.
So these are the few key points. I must say that though it's an uncommon, but it's really a serious complication, can occur after laparoscopic hysterectomy, and the incidence is 0.5%. And in open abdominal hysterectomy, it carries more high risk. The risk factors are large uterus because it can compress pelvic veins. I would like to ask one question here: why it is more common on left side? Anybody can take it. Why it's more, this DVT thing is more common on left side? Okay, it is common more on left side because the right common iliac artery, it compresses that left common iliac vein at the level of L5 vertebra. That's why. So the timing of surgery is also very important. Now this the timing of symptoms, which often appear late, it can appear as late as 1 to 2 weeks post-operatively. Then unilateral leg swelling, that is on the left side, is the hallmark, and the incidence can rise up to 11.4 centimeter when operating the cases of malignancies. And one of the independent risk factors is blood transfusion also. Fine.
This is the next case scenario. A 38-year-old lady came to OPD with complaints of excessive night sweats, irritability, dryness in vagina, and dyspareunia. She also gives history of hysterectomy done at a small town by general surgeon. So may I ask Dr. Deepak Gatti sir, what is your interpretation of such symptoms?
She's post-operative hysterectomy patient, and she's having symptoms of sweats, irritability, and dryness in vagina and dyspareunia, which indicates she's having premature menopause or premature ovarian failure.
Yes, like a surgeon has done, general surgeon has done the hysterectomy at small place where they do not respect the ovary. they do not respect ovaries. So it is general trend that to avoid further complications, they along with the uterus, mostly it is unindicated, and along with that they remove ovaries also. So it is a common scenario in our clinical practice.
Yes, even though
Okay.
the uterus only is removed, but if the vascularity of the ovary is not maintained, even though the
Yes.
patient may face the same
They
signs.
present earlier. They present earlier than the natural menopause.
But at least it will be gradual. It won't
Yes.
be abrupt.
It will take time.
So it will be gradual. But this
Yes.
is immediately a third, fourth day. Which
And
happens.
surgical menopause is worse. It is
Worse, it is
worse
worse.
than the natural menopause.
Yes, yes.
Yes.
So hysterectomy should always be combined with bilateral self-injectomy, always. When next question, my next question is to Dr. Karpe, madam. When should a gynecologist do opportunistic bilateral oophorectomy in high-risk patient and in routine patient, routine low-risk patients? What is your strategy in your practice? At what age? High risk, I mean to say, in patients of BRCA1, BRCA2, or patients with a history of ovarian malignancy in our first degree relative, it's a high risk patient.
Yes.
And low risk is a routine patient. So, what is the age criteria to do opportunistic oophorectomy?
If age group is more than 47 years, then we can do in low risk patient also.
Yes.
And
Yes.
in high risk patient above 45 years.
Yeah, BRCA1 it is 40, BRCA2 it is 45, and in routine patient we take it as a 50. 50 years. You are justified to remove the ovaries, to prevent one more malignancy or other benign problems or tumors in the ovary. Okay. So my question is to Dr. Ananya. If the oophorectomy is done in a patient with hysterectomy before the age of 50, and if she presents with the symptoms of hormone deficiency, so what HRT would you like to give her?
Sir, I would like to give her estrogen only hormone replacement therapy in the form of pills or patch form. And
Yes.
also, like in this patient, there is vaginal dryness. So, with oral, I would also like to give her vaginal estrogen.
Yes.
And menopause comes with deficiency of bone density is there in decrease in bone density, bone mineral density is also there. So, supplement her with calcium and vitamin D and advise her for weight training, strength training exercises.
Yes. Even supplementation of estrogen is going to take care of your bone strength and muscle strength, but there is no harm in adding calcium after the age of 40. So it's good policy to give hormone replacement therapy, and definitely it is going to prevent her immediate symptoms as well as long-term morbidity in terms of decreased events of coronary artery disease, osteopenia, fractures, Alzheimer's, etc. So you should be very serious regarding this hormone replacement therapy in your patients. It must be given in appropriate patients. Thank you.
So coming to our last case scenario, this one's for you, Ananya. A 60 years old symptomatic third degree uterovaginal prolapse case was operated, and we did a vaginal hysterectomy with pelvic floor repair under spinal anesthesia. The surgery continued for 2.5 hours in high lithotomy position using stirrups. On postoperative day 2, she complained of severe pain, tingling, and numbness in the part of thighs and calves. And while trying to stand up, she collapsed due to a giving way of right knee. And on examination, we found significant weakness of grade 0 to 2 or strength. So what is the diagnosis?
Ma'am, with the background of vaginal hysterectomy going on for 2.5 hours and the lithotomy, high lithotomy position using stirrups, this is
Yes.
most likely a nerve palsy, and mostly it is femoral nerve neuropraxia because there is problem with standing up, that is flexion at the hip joint is compromised.
Yes. So it looks like a femoral neuropathy, and I must say neuropraxia where least nerve damage has occurred and without nerve fiber disruptment, isn't it?
Yes,
So
ma'am.
how would you like to manage this case, Ananya?
So, ma'am, this management involves including multidisciplinary team, and counseling the patient here is very important. That
Yes.
uh,
Yes.
with the with time this
Counseling,
will get better.
reassurance. Mhm.
Counseling and reassurance that with time this will get better, and it
Yes.
can be supplemented with exercises with the help of physiotherapist. However,
Yes.
for the first few days, she is advised to take rest and not do any weight bearing.
Yes. Anything would you like to give her?
Maybe she
Medication.
would
Any medication would you like to prefer?
We can add
some
multivitamins.
For pain, we can give her
short,
analgesia.
Yes, madam.
some short course of steroids sometimes could be necessary.
Yes, yes. It can be one of the options.
pregabalin or something like that.
Yes, yes. We can give GABA antagonist also. So there is definitely a role of physiotherapy and rehabilitation, and we have to counsel and reassure her that she should not panic, and that this neuropraxia thing is there. So which is the mildest form of nerve injury, nerve damage, I must say, and that it is going to get resolved within a period of 8 weeks. And
Will there be a medico-legal complication with this? Just is sir there in this, or because the pain could be more to the patient, or maybe our explanation or our counseling would work, I think.
No, reassurance and counseling will work because see, like in my college, we come across the patients of third degree prolapse, not only
Yes.
such cases, but also of cases of huge precedentia with a big cystocele, and who even at the hands of expert do require time because of those tedious steps of pelvic floor repair, isn't it? So it's definitely going to be a time-consuming procedure, but I must recommend that one must be careful that the improper lithotomy position should not be given to such patients who are likely to have prolonged surgical time, isn't it? So improper lithotomy position should be avoided, and such patients should be taken care of properly post-op.
And use of well padded boot type stirrups.
Yes. The stirrups should be proper. So these are a few other types of nerve injuries post cystectomy.
Peroneal.
Yes, peroneal, obturator, ilioinguinal, and sciatic. So last but not the least, I would like to give you a word about Foxy policy statements on surgeons doing hysterectomy. Hysterectomy is a surgery where uterus is removed for different indications for health of women. Women need to be counseled about pros and cons related to removal of uterus and ovaries, pelvic floor defects, and different routes of removal of uterus like abdominal, vaginal, and laparoscopic before deciding on removal of uterus in reference with anticipated menopausal symptoms and signs. Next, please. And also that hysterectomy demands a sound knowledge about the science related to the removal of uterus and ovaries and pelvic floor defect, identification and correction, both before removal of uterus and as it also affects after the repair is performed. This can be offered best by gynecologist, and surgeon can be called in the event of involvement of other organs, especially bowel, I must recommend, and to assist in difficult situations. That's all for tonight, ladies and gentlemen. Thank you so much. And I would like to thank Dr. MC Patel also for giving me this opportunity to moderate this session.
And we wish him best of luck, and we see him as our next Foxy president.
Yes.
We also wish Dr. Anil Sakre sir for contesting the chairperson for vaginal surgeries.
All the best.
And thanks again for giving us the opportunity to be part of this excellent academic event.
Thank you.
So
And thank
big
you,
round of
Lakshmi ma'am,
applause
for your
for two
inputs.
learned moderator,
Thank you, sir.
Dr. Prisia and Dr. Pratapwar, for nicely conducting this panel, and all the panelists putting their inputs to make this panel interesting and fruitful. So thank you all.